Good morning. My name is Karen Brandon. I'm the president of the Physical Therapy Board of California. I'd like to call this meeting to order. The time is 9 o'clock. It is Wednesday, March 19, 2025. This is the second day of a two-day meeting of the Physical Therapy Board of California. Today, we are meeting in University of the Pacific, Stockton, Thomas Long School of Pharmacy, 751 Brookside Road, Stockton, California, 95211. Room D121. This is an official business meeting of the Physical Therapy Board. The board's role remains to maintain consumer protection and consult with local and state entities on the laws and regulations pertaining to the physical therapy industry. We will take public comment on specific agenda items, and at the end of the meeting, there will be a comment section for items not on the agenda. Public comments must be specific to the agenda item that is being discussed. If you make a comment during the specific agenda item that is not related to the topic, you will be directed to hold your comments until we reach the appropriate agenda item. All comments that do not directly relate to an item on the agenda should be held until the agenda item for items not on the agenda. The board follows the Open Meeting Act, so we will accept and appreciate the public's comments. While we cannot respond to those comments, we appreciate them. This meeting is being recorded and the minutes of the meeting will be prepared. Can I please have roll call?
Karen Brandon.
Here.
Sam Q.
Here.
Dale Armstrong. Dale Armstrong is absent. Katarina Ellaby. Katarina Ellaby is absent. Tanya McMillian.
Here.
Alicia Amen.
Here.
All members are present with the exception of Dale Armstrong and Katarina Ellaby, and the board has a quorum.
Thank you, Ms. Arntzen. May I please ask the distinguished Dr. Ravina Amen to read the mission statement of the board.
The mission of the Physical Therapy Board of California is to advance and protect the interests of the people of California by the effective administration of the Physical Therapy Practice Act.
Thank you so much. And now we are going to continue our meeting with the item agenda number 15. Mr. Kaiser, can you introduce the topic?
Yes, we have two guests from the Federations of State Boards of Physical Therapy. Leslie Adrian, who's the Director of Professional Standards, is going to do a presentation on essentially the national status of dry needling. If I could have Vincent cue up that meeting. And we also have Michelle Sigmund-Gaines, who is the Director, Board of Directors Liaison for the state of California, and also my counterpart as the Executive Officer of the Oregon Board of Physical Therapy. Vincent will cue up the first presentation, and I will hand it off to Leslie at that point.
Thank you, for inviting me to speak on this topic today.
Can you grab that, Leslie? The mic for the online people. Can I see her?
Okay, well, now I feel like I'm giving a performance. So again, my name is Leslie Adrian. I am a physical therapist. I'm the Director of Professional Standards at the Federation of State Boards of Physical Therapy, of which the California Board is a member. I did want to thank you for the invitation to come out and speak, and also from getting me away from the Midwest weather out to some really beautiful blue skies and some sun, which has been nice to see in March. So we talk about dry needling. It's gone by a few different names throughout the years. One is intramuscular needling, intermuscular manual therapy, but really the term of choice now is dry needling. And the definition of dry needling, which was actually tweaked from an earlier definition later last year, was in 2024. And this is the current definition by which the Federation is going by. And for the most part, the professional association's definition is very, very close to this also. But it's a skilled intervention performed by a physical therapist using needles to penetrate the skin and/or underlying tissues to affect functional change in anatomical structures and systems for the evaluation, management, and prevention of neuromusculoskeletal conditions, pain, movement impairments, and disability. I think one of the things to bring awareness to is the fact that we talk about neuromusculoskeletal conditions, and that'll become important as you start to talk about some of the comparison between dry needling and acupuncture. So I think one of the biggest things right now is that unlike one of the first few talks I would give on this topic, at this point, I feel very confident saying that dry needling is an established treatment. It's not new anymore. In 1989, Maryland became the first state to allow dry needling. And they had really no issues with that treatment and no disciplinary issues and nothing that spurred action on dry needling until there was kind of an onslaught of court actions and other actions. And then they had to, basically, they were told, well, the board policy that allowed dry needling isn't enough. You actually need to go through the rules making process. But it wasn't spurred by anything of specific patient harm or issues of that nature. It was really, really outside forces that requested an AG opinion, which then necessitated not the fact that dry needling was not in the scope. However, how the Maryland board got there wasn't in line with the way it needed to be done. So then they had to go through an official rules making process and kept it in place. So, but really it goes all the way back to 1989. And in 2010, that's when the FSBPT first published a resource paper on this topic. That was, I would say, the beginning of kind of the hubbub. And then for the next 5 to 6 years, it was a very, very hot topic throughout the states. And then in 2022, just another embracing of this as an intervention. There are now CPT codes that have been introduced for billing. So an acknowledgement that it is an established treatment and that lots of individuals doing it. And I will say that right now we may be talking about physical therapists, but there are other individuals that are performing this treatment. I know there are some states where chiropractors are doing this. There are some states where athletic trainers are doing this. So this is an intervention that when it makes sense for a profession to do, they're doing. So if you look at the state of dry needling in the USA as of December of 2024. All the green states allow it specifically. So that is 40. And then I don't have any information on Puerto Rico or the US Virgin Islands. So the FSBPT, we have 53 member jurisdictions. So that's where that number is going to come from. But I don't know about Puerto Rico or the US Virgin Islands. But all the greens are where it is specifically allowed one way or another. And I'll talk about that a little bit more in a minute. And then we have 6 states where it's silent. They really haven't said or come out and made any kind of public statement that said, yes, this is okay for physical therapists to do. And then we have 5 where it is specifically prohibited. And in Hawaii, they have an interesting caveat in their Practice Act that says that PTs aren't allowed to puncture the skin. So that pretty much eliminates other things like dry needling, EMG, needle EMG that PTs can do other places. So, now, with these 40 allowables, it runs the gamut. Many have it, over a dozen have it actually in their statute. So it's made as part of their Practice Act through statute. Many have done by board policy. Many started out by board policy, but then determined that they needed official rules. So they've gone back. So many of these states, dry needling has been incorporated into the scope of practice through rulemaking. There have been a number that were, like I said, in that 2010 to 2017 timeframe. There were a number of AG opinions that were sought by other organizations regarding PTs. And so those AG opinions, many of them came back favorably that PTs could have this within their scope of practice. And then there were several court cases. So how this 40 got there, it really varies, but those have been most of the avenues that have been taken. But as you can see at this point, I mean, the majority of the country is doing this treatment. And then I would add, and I believe the next speakers will address this too, but in both the VA and the military, this is allowed to be performed. So it would be all green, right? So if you are a person who's able to access treatment through a VA center or or the Department of Defense through a military treatment facility, you will be able to access just treatment regardless of where you are, as long as they have a person there that can provide the treatment. So this has always been the question: who owns dry needling, right? The answer to this question is there isn't a single profession that owns any procedure or intervention. I'm not here to tell you that dry needling should only be done by physical therapists. If the athletic trainers or the chiropractors or occupational therapists are able to demonstrate that they are able to do this safely, it is an intervention that we can give to the public through another provider that they can access. This isn't gatekeeping. This is really saying, and there's overlap among professions. It's expected and it's necessary for access to high quality care. There are acupuncturists that are using electric stimulation. PTs use electric stimulation. There are chiropractors that use ultrasound. Physical therapists use ultrasound. There are things that acupressure. PTs use acupressure. That's never been really in question. You do your surface anatomy, you find trigger points, you apply pressure, and that has just been part of the treatment for a long time. It's also part of the acupuncturist scope of practice. So it isn't about owning a specific procedure that makes you the one thing that you are. So it's just like PTs, just because we're mobility specialists and we do exercise, it doesn't mean that that's all that we are. So when you think about if a profession is looking at something quote unquote new to them, you've got to look at some foundational areas to figure out if this is in the public's best interest. And this is from a document on the FSBPT's website. It was a collaborative effort between 7 regulatory agencies, all similar to FSBPT, that came together, and it's really a legislative aid to understanding changes to scope of practice. So is there a historical basis for the X thing in question? So for our question, it would be dry needling. So you could ask yourself, has there been an evolution of the profession towards the addition of dry needling? I think we can see that has definitely happened throughout the last 15 years. And dry needling, ask yourself, does something enhance the current expertise of the profession? This is another tool in the toolbox of a physical therapist. And like everything else that a PT does or PTA does, they have to make sure that their personal scope of practice, that they know how to do it. You would not want me to go into a school and treat kids with developmental disabilities. My license says I can, but it wouldn't be a good idea. I would know that there's a lot of work that I need to do before I could do that safely or practice that aspect of physical therapy effectively and safely and be competent to do that, right? That's part of my professional understanding, my professional responsibility. And you have to realize, right? You guys give out licenses for PTs to do a wide berth of things. And we do trust that the majority of them are going to use that professional responsibility in order to keep themselves only within their own profession or their personal scope of competence, right? And this is the same type of thing. I personally wouldn't do dry needling. I haven't been trained in it. I've had it done as a patient. 3 of my family members have received it as patients, but I haven't said, oh, well, I'll just do it at home now for them because I can, because I haven't been trained in it, and that would be irresponsible of me. So education and training. Does the current level of education prepare physical therapists to do dry needling? I'm going to give you some information in a bit that I think will help answer that question for you. And that has been a question that has been posed multiple times as the argument as to why a PT should not be able to do this. And are there training programs available to fill in the gaps where the entry-level education does not meet standards? And the answer to that question is yes. Is there evidence and research to support the effectiveness? There is. In this case, there's been more and more and more work done on dry needling. So we have a body of evidence that we can look at now. And if you do a literature search, it will yield extensive results for this. And the regulatory environment, well, we're here. This already answers that question. You do have the regulatory environment. You have a board that has sufficient authority to discipline someone who does this wrong, creates harm, goes outside of your training requirements. And the board here is authorized to develop rules. So there are professions that can't answer that question in the affirmative. So it may not be a good fit. So as I said earlier, one activity does not define a profession. It's that entire scope of activities that you bring within a practice that makes any particular profession unique. By adding something to the PT scope of practice, it does not detract from another profession because there are many things that someone else can offer that a PT cannot, even if they can add this into their toolbox, as I said. Simply because a skill or an activity is one profession's skill set, it doesn't mean that another profession cannot and should not include it in its own scope of practice. And this again, that's from that same document. It's called Changes in Healthcare Professions Scope of Practice, Legislative Concerns or Considerations. And this is on the FSBPT website.
Leslie, is it okay if I ask a question? That was the paper that you said was a collaborative effort.
It was, there's 7 organizations. It was social work, nurses, pharmacy. There were 7 total.
Thank you.
All federal regulatory, federations, so similar to FSBPT. So this is a question that has been asked many times over the last few years when I've had to speak on this topic. Dry needling versus acupuncture. If you allow PTs to do dry needling, aren't they really starting to get into the acupuncture scope of practice? Well, acupuncture, there are many ways that this is different, right? I actually think it's an insult to acupuncturists to say that dry needling is what makes them what they are and who they are as a profession. Acupuncture is based on traditional Chinese medicine. I can tell you that physical therapists using dry needling are not basing it on ancient Chinese medicine. Dry needling is based on neuromusculoskeletal evaluation and management. And that's why I was saying that was part of that definition that made it so important. PTs using dry needling do not, and if they do, they should be brought before a board. They should be disciplined if they do any of these things. If they use acupuncture, traditional Chinese medicine theories, meridian acupoints, and terminology, if they use acupuncture diagnosis like tongue and pulse, if they use the idea of energy flow or meridians, or if they address issues that are far out of our scope, typically fertility, smoking cessation, allergies, depression, and other non-neuromusculoskeletal conditions, right? So there shouldn't be a PT that hangs up a shingle that says, I can treat your allergies with dry needling. And if they do, there should be a complaint and it should come before this board. They do not, and they cannot claim to practice acupuncture. And if they do so, then that's wrong. So we talk a little bit about PT education and preparation. Again, this has been a question for many years. Are PTs really prepared to do this intervention? This question was asked of the Federation over a decade ago. And we didn't have the answer for them. We didn't have the answer for our member boards to say, well, really, in their entry-level education, they get a lot of this, or yes, they're prepared to do this with a little more training. We didn't have that answer for our board or for our member boards. And so we went out to get the answer for them. This is a collaborative effort. We felt that this really needed to be an objective outside study, if possible, in order to lend credence to the study. So this is an effort between FSBPT, the Healthcare Regulatory Research Institute, which is a research arm, and it's broader than just physical therapy. It's looking at regulatory research in general. And then the Human Resources Research Organization, they do a lot with job analysis. That's one of the things that they do. So we called this our dry needling competencies study. The background to this, HUMRO, we brought on this external consultant that has, the objectivity that will allow for greater defensibility of the findings. They did a thorough review of entry-level physical therapist requirements and the comprehensive practice analysis to delineate the competencies that are necessary for PTs to safely and effectively perform dry needling. And in 2015 is when we first did the first dry needling competency study. And this was, as I said, in response to a member's request for support and help. We created a definition, defined the minimum competency requirements, and defined how much preparation is already part of entry-level PT education. And if you think about this, this was 2015. So that was prior to, I believe, and you can catch me if I'm wrong, but I believe that was prior to the accrediting organization, CAPD, requiring that all programs have moved to a DPT. So now there's even more credence, I think, to the education for PTs. So 2020, there was an updated practice analysis for the National Physical Therapy exam. I'll explain why that was important. And that necessitated an update to the dry needling competencies. And then in 2024, the same thing. So our subject matter experts were 10 physical therapists. This last one in 2024, there's always been at least 10. It's varied between 10 and a dozen subject matter experts on the task force. So this last one in 24, there were 10 physical therapists with experience either performing or teaching dry needling. And one of the things I thought was awesome, because every one of the folks had either did dry needling or taught dry needling, right? So 6 of those 10 people were actually currently serving or had served on a regulatory board. So, which I can tell you that those numbers are very, very different from what that original task force makeup was, where we had board members that said, I've never heard of dry needling. I've never heard of a PT having a needle in their hand to do anything except DMG. What are you talking about? So the goals of this task force were to review and update the definition of dry needling to ensure it still reflected current practice, because again, it was 15 years old at that point. To assess the current state of competencies needed by PTs to perform dry needling safely and effectively, which has really always been our goal. It's always about a competent level to allow for safe and effective practice. Because you can practice safely, but not do anything for your patient. And that's a waste of their time. It's a waste of financial resources. You still have to, those 2 pieces really work together. And then determine the need for additional research to ensure the competencies accurately and faithfully represent the dry needling domain of practice. The way that this was done to really look at entry-level education and where entry-level PTs come out is linking this to the National Physical Therapy Examination, which, if any of you don't know, FSBPT is the designer and the administrator of the National Physical Therapy Examination. So HUMRO, the company that helped with this dry needling competency study, is the organization that we use to do the practice analysis of physical therapy, physical therapist scope and physical therapist assistant scope, for when they're designing the new test blueprint and what should and shouldn't be required on the National Physical Therapy Examination. So they have a strong link to us and a strong understanding of the development of the examination. So a key step was a thorough review of entry-level physical therapy education requirements specified on the content outlined for the National Physical Therapist Examination Licensure Exam. So that's where we start. And then the NPT content outline list, and this is where the abbreviations are going to get a little, so I hope we can sort of stay in line. But WAs are work activities and KSRs are knowledge, skills, requirements. So that's what this means. And that's just the way that the practice analysis is done for the test itself. So there's this long list of work activities and this long list of KSRs that are going to end up on the test. And then it reflects the knowledge, skills physical therapy students acquire during their formative education. And we can all say, you know, it really depends on where you go on your clinicals too, right? There will be people who have never seen dry needling done when they graduate, and there are some that will have done it on their clinicals. It's like everything, right? It's who you end up with, really. Like I could have ended, you know, when you're with someone who does a ton of manual therapy in their treatment, then as a clinical, you'll have that strong basis when, you know, you graduate. But and we all accept that in education, right? That it all depends on who you were with for what you are exposed to as a student. So the study's results led to a creation of 2 lists of work and worker requirements identified as relevant and important to dry needling. So HMRO basically has done a huge practice analysis on the entire scope of physical therapy, right? But then what they're going to do is basically do a mini one on just dry needling as an intervention. So think of it as a practice analysis of dry needling, which is really weird. Let's be honest. We don't do that with any other intervention that we do. We don't have competencies for TheraX that we go through and, you know, look at. So, but this is really what we needed to do because this was definitely a little bit different than other things that have traditionally been done in PT practice. So there are 123 work activities that physical therapists carry out when performing dry needling. So of that huge list for the entire physical therapy examination, 123 work activities were pulled out that seemed relevant to dry needling. 117 knowledge and skills requirements that physical therapists must possess to perform the work activities safely and effectively. So 117 for dry needling out of that whole entire giant list. So our link to the practice analysis, 2016, we had conducted 2 comprehensive practice analysis of the whole profession, right? That resulted in adjustments to the NPTE content outline and exam blueprint weights. So when the exam changes and the blueprint changes, that's when we go back to the original competency study on dry needling and said, oh, we need to do an update. So it's not like this has been a one and done where we looked at it once and said, oh yeah, we're good. No need to worry. Every time the exam changes, every time the blueprint changes, we go back, we reconvene a task force and look at it again and go through all the steps and pull out all the work activities and pull out all the KSRs that say whether or not they are applicable to dry needling. And then in 2018, we started conducting, so we used to do these practice analysis every 5 years, and they would be like a huge undertaking. So in 2018, we started conducting annual practice analysis surveys to evaluate trend in physical therapy practice because there were more things happening really in the profession. So it's making sure that we're not missing anything on the exam. And then in 2020, we took another look. We made sure HRRI, the Research Institute, conducted a content validity study to determine that, again, the changes that were made to NPTE content were reflected in the 2016 dry needling competency study. We went back and looked at it again. And then 2022, again, the changes that were made to the work activities and the KSRs are reviewed by the task force, primarily based on updates for the MPTE content outline in 2022. And then that brought us to the 2024. I know this timeline's a little confusing because it's basically when the practice analysis were done for the actual exam versus then when the dry needling competencies were looked at. But basically, the bottom line is if the exam changed, then we went back and reviewed, and that's why there's been 3 studies in total. So the link to the NPTE is a review and acceptance of many of these changes. So the changes that were done to the NPTE practice analysis that the task force reviewed and accepted many of these changes to preserve the empirical link between the NPTE content outline and the dry needling competencies. And this is the thing that we feel very strongly about, is that we already know that the NPTE is a valid and reliable measure. And so being able to link the dry needling competencies to it, we felt was very important. So that's why we've continued to update them and make sure that this empirical link remains. We continue to support the conclusion that much of the knowledge and skills needed to perform dry needling is actually acquired during a PT's entry-level education. And the updated set of dry needling competencies includes 144 work activities, 133 knowledge requirements, and 20 skills and abilities. So that's the little piece, the dry needling analysis versus the entirety. So when it comes specific dry needling education. So let's take out what we've already talked about with entry-level education, and this would be very specific to dry needling. There, of all of that big number that I told you, there were 16 knowledge requirements that are specific to dry needling that need to be acquired through advanced or specialized training. And as noted in the 2015 and the 2020 dry needling reports, so we keep coming to the same conclusion, dry needling specific knowledge is predominantly related to that needling technique. So selecting needles, where to place needles, the contraindications for doing dry needling, emergency preparedness specifically to needling, and the emergency response. So I think that this chart is the one that is really like kind of just hits you in the face and says, oh, wow, okay, yeah, PTs are really, our entry-level education for a long time in those beginning years I was telling you about, acupuncturists, and I coming back to the acupuncturist because for the longest time, that was really the core group that was making the case that this was not something that physical therapists should be doing. So that's why I'm referring to them. They were really asserting that if a PT wanted to do dry needling, they needed to go to acupuncture school. And again, we can harken back to those things that I talked about with regard to a scope of practice and what makes a profession unique and special. And there were so many things that would have been taught in an acupuncture program that would have had no bearing on doing dry needling and just didn't make any sense, right? When we look at this and we say, 88% of what you needed to do dry needling. So that practice analysis of dry needling, those work activities, the knowledge, the skills, the abilities, requirements, 88% of those are already in a PT's entry-level education. Now, do they have 100%? No. Do they have everything they need? No. But there's about 12% that's unique to dry needling, where a person who's really interested in doing this needs to go out and get additional information. Now, I will say really at this point, there's probably students that are graduating that have had that because of where their clinical placements are or because of where they went to school. There are some schools that they have some very strong instructors as part of, the staff, as part of the faculty, that this is something that they believe strongly in, so they're teaching it to students. So one of the things that I would caution you, many states, if you look at their training requirements or some other requirements for doing dry needling, they actually restrict it to individuals who have, 1 year experience or 2 years experience. They don't allow new grads to do it. I would say in some cases, new grads are actually better prepared to do this than people that have had many years of experience. So that's something I would caution you if you were going to have conversations about this and look at what other states have done. So when you talk about gathering information, determining a treatment plan, documenting a plan of care in progress, all things that are really important to dry needling, they're all really important to physical therapy. And PTs have learned how to do those things. And that small proportion of additional knowledge and skills must be developed through postgraduate or specialized training in dry needling, or, be able to demonstrate that you had it in your entry-level program. Because that's something I couldn't have said a few years ago. It's something I feel confident saying now, that there are some new graduates that are coming out that have received that extra 12% as part of their schooling. So these are the list of the specific knowledge to dry needling. So we get lots of surface anatomy, but you have to be really good at it as a dry needler, honestly. And making sure that you are very specific on the tissues and the structures that you're needling. And then a lot of it has to do with emergency preparedness and response specific to needling and issues that can happen to needling. It's not an intervention that is completely risk-free, but I would argue really nothing is. Right? Everything has a risk associated to it. And when you know what you're doing, the risk goes down significantly. But there are things that can happen and you need to be ready to take care of those. So again, down here, a lot of these needle insertion techniques, needle manipulation, the physiological responses to dry needling, needle characteristics, very specific to dry needling itself. So big questions. Is this safe? If PTs do this, are we going to see a rash of pneumothoraxes across California? Or is there going to be, massive levels of infections? So far, the information that we have says no. So the FSBPT has something called the Examination, Licensure, and Disciplinary Database, where our member boards report to us their licensure actions or disciplinary actions. We don't have 100% participation, but we have a very high level of participation. And states that don't provide the data, many of them, we seek out their data. So we have staff members that is their job, and they go out and do that. I'm sure that Jason has spoken to you all about the ELDD at some point. He's been very involved in that with the Federation. The Federation feels that the ELDD is our second most important public protection tool behind the NPTE. So looking at a review from January 1st, 2010 through October 31st of 2023, go back to what I said, Maryland, they had started doing dry needling in 1989. Prior to 2010, there were 0 cases related to dry needling in the ELDD. So there was nothing to pull from, excuse me. But we had 5,025 disciplinary actions that were entered into our database in those 13 years. 22 of those were related to dry needling. So that's 0.43% of all the disciplinary actions. And the funny thing was most of these had to do with getting proper informed consent as per the law, the policy, or the regulations in that state, the documentation, and billing, rather than actual issues with performing the technique or creating harm to the patient. Now, there were a few that I thought, I'm not going to hide from these, and people should know. 2023, there was a case of a PT who he or she forgot to remove 2 of the needles prior to sending the patient on their way home. 2021, there was 1 case of a pneumothorax. And in 2017, there was an individual that was needling auricular points, and that is outside the scope of a PT, just like the earlier slide where I said what PTs that are do dry needling should not be doing as part of that intervention. So in conclusion, at this point, I think it's safe to say that dry needling is a reasonable intervention to add to the PT's toolbox. The public benefits from having a variety of treatments available from a variety of different providers. And the safety record is pretty good. So that is the end of what I wanted to share with you today.
Before we move on, ask a question.
Does the board have any questions to ask of the presenter?
I don't have a question. I just have a statement. You said the safety record is pretty good. I think the safety record is excellent in the presentation. So, yeah.
Just want to say thank you, Leslie, for making the trip all the way across the country and presenting this information. this is exactly what we were interested in hearing and even more. So thank you again for presenting and presenting the information also to the various stakeholders and also the public, the consumers of California. Appreciate it.
I'm happy to do so, and thank you for the invitation.
Any public comment?
Good morning, everyone. Thank you for that presentation. So my name is Nicolo DeLuca, and I'm very happy to be here this morning, so thank you. I am here this morning on behalf of the California Acupuncture Coalition, and we're a federation of California's largest acupuncture associations, led by the American Association of Chinese Medicine and Acupuncture, the Association of Korean Asian Medicine and Acupuncture of California, and the California State Oriental Medical Association, and in conjunction with many, many universities and schools. We'll also submit a letter to help kind of provide additional comment. Again, I appreciate the presentation. We come in the spirit of collaboration and working together. We do feel strongly that dry needling is acupuncture, and that needs to be, any dry needling needs to be performed by a certified licensed acupuncturist. We go through many years of training, and we feel strongly it's in the best interest of the consumer. I do want to be clear, we come in the spirit of collaboration, would love to work with your board, obviously the California Acupuncture Board, and many others, and potentially if there's an opportunity where we could all kind of work together, kind of speak about what some of our concerns are, but do want to get it on the record that we do feel strongly that any practice of dry needling is acupuncture, and any form of acupuncture should be performed by a certified licensed acupuncturist. So those are our comments. Again, I'm here on behalf of the coalition. We have many thousands of doctors and a lot of our students. Look forward to working together in the spirit of partnership, and just wanted to get that on the record of how we feel. And we're here as a resource. We believe in openness and collaboration. So really appreciate everyone's time this morning and that of the presentation. So thank you very much.
Thank you. Any other public comment? Okay.
Maybe a 5-minute break just to prep for the next.
Okay, we
presentation.
have another presentation. We'll take a quick recess and get back here 10 till 10. Thank you.
Michelle isn't speaking. Michelle isn't speaking. Oh, you mean, this is the next topic? Yeah, this is, number 16, correct. And then she'll speak for number 17.
Yep.
Okay, we're returning back to the PT Board of California Board Meeting Agenda Item number 16. Mr. Kaiser, can you introduce the presenters?
I'm going to have them introduce themselves, but we have three gentlemen from Palo Alto from the Department of Defense and Veterans Affairs that were with us in 2017, 2018 to do a presentation very similar to this. So it's nice to see you all again. Thank you for coming. Thank you for making the trip. And I'll hand it off to you.
Thank you very much. So as mentioned, my name is Taylor Dearnels. I'm with my colleagues, Jerome Sabrian and Rick Castillo. So we're here. We work for the Department of Veterans Affairs healthcare system. And many years ago, we asked to present because we're in a unique position within the DoD and VHA that dry needling is a common practice that we've been utilizing for over a decade now and training and development of our staff within the system. So we're just here as on behalf of private citizens is to kind of share our experience and share the knowledge with everyone of how the practice is utilized and how it's developed over time. And with that, full disclosure, so everything shared in here, some of the information comes from our healthcare system, but we're here and the thoughts and opinions are ours alone and do not represent the DoD or VHA. All right, so our goal of this presentation is this kind of level set, discuss how we use it in our system, how it's been spreading and growing, and how it's utilized in practice, and an interdisciplinary approach with our colleagues in the healthcare system, and then just level set of its use and evidence and the foundation of the practice in general. So long story short, so about over a decade ago, obviously we work collaboratively with the DoD, so active duty soldiers and veterans come within our healthcare system. So we treat both. And so the DoD has a long withstanding history of physical therapists need to be trained in dry needling and oralized utilizer practice because they're deployed on the front line. And so they need to keep active duty soldiers mission ready for deployment. And so there's a lot of nuances within that, if an active duty soldier is on some kind of pharmacological medication, they can't utilize some heavy equipment. So PT's there on the front line to treat and mitigate that. So they're mission ready. And so on the other end, on the other foot, so when they come to us, we recognize there shouldn't be a gap in care. So when they leave active duty or they're treated with our healthcare system, active duty veterans, we need to be also trained equally as them so we can deliver the same model of care. And so with that, we've been collaborating. We started locally with our local Air Force and set up a training of our staff within the VHA over a decade ago so they can get trained in dry needling. And then we in turn developed our own internal training and modeling system so that we can spread it across the VHA. Because about a decade ago, there was dry needling existing, but it wasn't standardized, uniform. We had to get training out in the private sector. And we just decided within our healthcare system that it makes sense to standardize with the DoD to have a uniform kind of delivery of care. And so where we exist now in 2024, so we have a national dry needling training healthcare system and research enterprise. So what we do, myself and we have a network of trainers, is we train throughout the United States, all the different VAs. So when there's enough new PTs that want to do dry needling course, we'll deploy our staff. Either they'll come to us in California, or we'll go to their local site, run a class, do the training, get them certified and competent, so they in turn can treat in their clinics through all therapists. And so now, and recently in the last year, we've hired a researcher. So we've been collating, collecting our data from treatments, and we'll hopefully over the next few years start publishing a lot of VHA specific research related to dry needling that we've been doing over the last decade. And so just for context, obviously in the VHA, we do it nationally and just a level set. There's still a few states that it's not legal to practice in, obviously. California is one of them. And then there's a couple gray area states where there's no opinion. But as you can see, nationally, there's 39 states that is allowed and utilized in their areas. And we're just here to try to promote and advocate for that and share our experiences. So we'll go ahead and go through our slides and then we'll be happy to take questions at the end.
Okay, so unfortunately, we missed part of the presentation beforehand, but what is dry needling? I'm sure y'all have gone through quite a bit of this. But initially was dry needling was defined as a treatment that involves a very thin needle that is pushed through the skin to stimulate a trigger point. Now, that has changed a lot, but we'll go over that a little bit. So dry needling, because it does not involve any medication use, you're just going through there, and we're looking to find the myofascial junction or a trigger point. And when this happened, it started with injections, and I'll go over that study in a few slides up. But they did find out that after the study that the same results could be found without using medication, just stimulation of the needle. Over time, the needle or the hypodermic needle was replaced by a thin filament. All right. So what is a trigger point? So it's defined as a highly localized irritable spot in in palpation. It's a taut band or skeletal muscle fibers. There are two basic types. If you look here, it says active, which an active and a passive. Active trigger point causes symptoms to the patient just without any type of palpation. It's always there. You may have even a referral pattern. Whereas a passive trigger point will be, it will be activated once you press on it. It could be just local tenderness, or it could also go down a referral pattern. Okay. Here we go. Okay, that is fine.
For those listening online, just give us a moment. We're having technical difficulties, but it'll be right back up. Okay, go for it.
So there are characteristics of snap or we call under restriction in the trigger itself. into that muscle.
Mm.
Our little lifestyle. And some of the things we know about her, right? First,
Wait 1 second. Now try.
how about now?
Yep.
Okay. Okay. All right. So there is some evidence to support what we know about myofascial trigger points. There was severe hypoxia around the vicinity of those trigger points. The increased energy demand around the sarcomere also shortens the taut bands, producing a local energy crisis. There's one called the integrated trigger point hypothesis as well. Active trigger points have increased inflammatory mediators around there because you are having a decrease in pH. And it can be imaged through magnetic resonance elastography, or MRE. I've never seen that before, as you can see here, that it shows that hypoechoic trigger point area. However, we have been able to use ultrasound to look at some of how dry needling can affect those structures. For those who have never seen these are just a referral pattern of myofascial trigger points. Above on the top is from your levator scapulae, which is right around your shoulder. But as you can see, it can cause some pain referrals down the middle of your back and also to your shoulder. The one in the middle, that is your gluteus medius, which, as you can see, looks like and can actually mimic a lot of a condition where people are known as sciatica. And the other one on the bottom there, that's your infraspinatus, and that can mimic things like C5, C6 radiculopathy. And also for some people who think, oh, I might be having a heart attack. So sometimes these are just more so like musculoskeletal related. All right. So currently how we treat trigger points non-invasively as physical therapists and even other providers, you can stretch, use TENS, ultrasound, lasers, pressure point, fluid sprays, etc. Invasive wise for physicians, they can put in local anesthesia, steroid injections, Botox, and we can, do dry needling in some states now. All right. However, dry needling has evolved a lot, and it's not that we're looking at trigger points anymore. When you think about trigger points, they talk about being in the muscle themselves, but if you look at some of the data, it's really, they talk about trigger points being around the fascial planes as well. But when we look at trigger points, and what was discussed earlier, that, we are looking at, and dry needling, we are looking at addressing musculoskeletal problems. But not only are we going right into the muscle tissue itself, but we're also going to using it on tendons, the tenoosseous junction, muscle bands, the fascia itself, close to the nerve roots. We also look at not being so specific to be in that one, in the one muscle, but the whole area, and also looking at innervation fields or following nerve tracks. All right, and I did talk about this just the last slide, but some of our goals when we want to dry needling is, well, everybody talks about pain when you talk about dry needling and myofascial trigger points, but it's really much more than just pain. We're really trying to increase range of motion because as physical therapists, we want to make sure that we improve function. And that's, that's very, very important because this is not, when we perform dry needling, it's very rarely ever just a standalone treatment. We're always using it with a lot of the other modalities and interventions that we use as physical therapists. Because we are causing, because we are piercing the skin, we're inducing an acute inflammatory process, and there is increased oxygenation. And at times, it is a little noxious, and you can actually stimulate or create what we call an endogenous opioid release. This study is by Carl Lewitt. He was doing a study for steroid injections versus a control study here. And what he found out that was called the needle effect, that the study between the control and the steroid, using the steroid was almost about the same. So they were concluding, well, maybe it's not so much from the steroid itself or the injectate, but maybe just from the mechanical stimulation of the tissue. But if you look at some of the structures that he actually looked at, I mean, you'll see like the levator scapulae muscle there, you'll see the trapezius muscle, but he's also looking at areas like the posterior arch of C1, scar tissue, pelvic ligaments. So there are other places where he was, these places were doing close to steroid injections, but things that we're also doing with dry needling that we're finding very good effects. Some of the techniques that we use can be very superficial. Sometimes very deep. We also do it with electrical stimulation and sometimes positioning, especially if you're looking at somebody with spasticity, we want to put them a little bit more stretch. Physiological effects of dry needling. We covered a little bit about myofascial trigger points, but here with dry needling, you can increase the blood flow. There's decreased banding. Over on the right, that slide, there's EMGs, trigger points from electrical activity from intramuscular EMG and also just surface electrodes. And you can see on the left, there's a lot more electrical activity versus a non-trigger point on the right. All right. Back. All right. So in the previous presentation, they talked about things that you need to know after, after schooling or after, your primary schooling to be able to learn how to drive needling. One of them was contraindications. Now, these are some of the contraindications that we look at. Absolute, local infection or tumor, lymphedema. Somebody has needle phobia. We don't dry needle them. It's something that, one, you have to respect that, that they don't like needles. And also that it's probably not going to help them if they don't believe in what's going on anyway. So that's one thing. And also if a patient is unable to provide consent. So we're looking at people with patients with traumatic brain injuries, patients that may have dementia or even altered mental status. Relative contraindications, and these are not all inclusive, but we have bleeding disorders. We've taken a little bit further where I work. Looking at vascular disease, diabetes. Obviously, we don't want to go more distal to the area, compromise immune system, pregnancy in the first trimester. I don't think a lot of people do that with anything. And over joint replacement, cardiac pacemaker. And if you look at these are a lot of the relative contraindications. Doesn't mean that you cannot, but you have to use your best judgment. I actually have a pacemaker and I get dry needles still. So still here. When it comes to post-op areas, we want to be very careful too. So immediate post-op area, it is recommended that you wait at least 3 months, and a region surrounding would be around 8 weeks. Okay. So is dry needling safe to be performed by physical therapists? This study was done in 2014 and actually was done in Ireland. Right, University of Dublin, University of Limerick, and Shenandoah University, which is on the East Coast. And it involved 39 physiotherapists or physical therapists over a 10-month period. There was almost 7,600 sessions. And here, if you see, like there was 463 mild adverse effects that were reported, were about 19%. And there were no significant adverse effects that were reported during this study. Now, when you're talking about mild adverse effects, some of them are things that even if you got an injection or maybe a vaccine. So there might be a little bruising, bleeding, they may hurt a little bit and pain following. Uncommon, and they're not mild, but uncommon effects that you may have are aggravations of symptoms, some drowsiness or a little bit of vasovagal type of reactions, headache, nausea. And from that, it was very, very low, it's less than 0.01%. So looking at dry needling versus other type of interventions, I know that, we're going through an opioid crisis throughout our, our nation. But if you look here, some of the, like just minor adverse effects that you may have versus some major adverse effects, even with non-steroidal anti-inflammatory drugs, you have a lot of people who have, just GI issues from that, but also it could be hospitalizations from that and also GI bleeds. I mean, it's still pretty low, 6-7%. However, when you look at things that as physical therapists that we could provide manual therapy, it's still less than 1%, and dry needling, it's, 0.1%. So safety of dry needling versus medical management. And we work very closely with our physicians in Palo Alto. A lot of them like for us to try to do dry needling prior to doing this for a variation of reasons. One of, if you look at for NSAIDs, there are increases risks of heart attacks, strokes, GI bleed, ulcers, corticosteroid injections, cartilage damage, weakness, tendons, weakened tendons, bone death, nerve damage, and which they only recommend to do those injections once every quarter. Botox, I work spinal cord injury. It's a great way to help patients when they are coming out of spinal shock and for their spasticity. However, because there is residual weakness, can affect their acute rehabilitation process. So the physicians on spinal cord, they're usually like, hey, Rick, can you go see them first to see if this works? If the dry needling works, then we can go ahead and on our way and continue our, our treatments and, for acute rehabilitation. However, if they're not having as good results, then they'll go ahead and, do the Botox injection. And of course, we know about opioids. So, the highest is of addiction and abuse versus something like dry needling. I was lucky also, the presentation before I talked about PT education and competency. So this was the Human Resources Research Organization, or the HMRO report. So if it's okay, I would like to skip through this since you already know a little bit more about that. All right. And when it comes to, there was another thing was of the 12% that needed to be known to be able to dry needle. One of them was also surface anatomy, also being a palpation. When we talk to our physical therapists, or even when we teach the courses, we always teach them that your non-needling hand or your palpation hand is much more important. You need to have that, because if you don't know what you're needling or if you can't find a dysfunction, you shouldn't be there. So we always teach that. It's always good to know the skill and the needle and handling skills, which you will learn, but it is the non-needling hand that is more important. But this study, and it's an older study in 2005, a description of physical therapist knowledge regarding managing musculoskeletal conditions. And this was a survey and like a little test or exam that they took. And if you look, there was 174 PT students and 182 licensed physical therapists. The same examination was also given to other people, like to orthopedists, to medical students, to psychiatrists. And as you have here, some of the physical therapists, they have some physical therapists who have specialties, the OCS or the SCS, physical therapists that did not have any type of specialization, and they also just had students from physical therapy programs. Over the chart, if you look, only the orthopedists really had knew more about expertise than even the PT students here. So if you look here from the PT, the OCSs down to the physical therapy students, after that, then you'll start to see like family practitioners, interns, residents, pediatrics. Current evidence, dry needling has been around for a long time. We know since about the 1980s. But there is always continuing education and systematic reviews that happen. I have a few of them here. This one, the clinical effectiveness of dry needling in patients with musculoskeletal pain. It was an umbrella review. They went over about 1,700 cases of systematic reviews of all different parts of the body. Now, something that I really want to hit home here is, says there is strong evidence that dry needling causes pain reduction across all parts of the body. but it also talks, it may be of additional value to interventions that are already used to date in clinical practice. So this shows that this is not just about dry needling, but other things that we do as physical therapists. This one is the effects of dry needling with chronic low back pain. There was 50 people in this study, and they are saying here, when supplemented by an exercise program, dry needling was effectively managing low back pain symptoms. Again, it's not just dry needling, it's also other things that we do as physical therapists with the exercise program. Again, this one is a study for dry needling on 40 athletes that have myofascial pain syndrome. So anything from upper back, levator scapulae, infraspinatus down to the glute medius. This has shown that the athletes felt that dry needling has significantly influenced the quality of life in, within with what they're doing. And of course, as being athletes, they are doing a lot of exercises. And one more study that I have here is about dry needling and tension headaches. The end showed positive effects in reducing the number of active myofascial trigger points for headaches and improving the intensity of short-term headaches in patients with tension-type headaches. Some of the areas that we look at when we're looking at headaches like this, we're looking at muscular as the sternocleidomastoid, the suboccipital muscles, levator scapulae, upper traps. A lot of, if you remember some of those referral patterns, you get a lot of that. And because you have some structures, you have the occipital nerve and the vertebral really may get caught up around the suboccipital muscles, in the suboccipital triangle. Those can cause a lot of those tension headaches that a lot of people suffer from.
Thanks, Rick. So as Rick mentioned earlier, dry needling complements physical therapy, and it's never a standalone process or procedure, right? Or modality. It's called modality. The physical therapist is always going to do a full evaluation, right? Or assessment. That's always going to happen. They're going to do their subjective. They're going to do their objective. They're going to measure range of motion. They're going to palpate. They're going to do their musculoskeletal evaluation, whatever needs to be done. And maybe even during that first session, it might not even include dry needling. They might use all those different techniques like Rick mentioned. They might, implement the home exercise program. That may be the very first step. We need the patient to buy in to this home exercise program. And then we might find later, maybe in the second or third treatment, hey, this patient's really going to benefit from dry needling. All right. The key take home thing we want to bring here is that it's a tool in our huge physical therapy toolbox. In regards to other emerging areas, what you'll see now is using dry needling with ultrasound. Rick mentioned we are treating tendons now. Perineural, so around the nerves, periosteocytes, because we're thinking about attachments, right? Origin and insertions. Spasticity reduction. So if you have any questions regarding that later, please reach out to Rick, because Rick is a spinal cord injury, and we are seeing improvement with spasticity. And what you also see out in the field are strategies. So there's certain types of training that's being taught out there. Well, they'll put needles in certain areas because of they're following research and proven, I guess, guidelines that would help in regards to patient areas. So for instance, there might be a strategy for hip pain. And so you'll see needles placed in certain areas based on studies. As I mentioned, we are doing more dry needling for neurological conditions, spasticity management. A lot of the past, when it first started in regards to, at least in Palo Alto, we were focused on pain, but we're now more focused on function, right? We want to improve the patient's function, and this is what really physical therapy is all about. We want to increase range of motion, their ability to sit to stand, and all the ADLs and whatnot. You're going to see more dry needling in regards to neuropathic pain. So a lot of times you'll see patients with maybe like a CPRS, right? You might not needle directly into the area of the pain, but maybe needling in other areas and introducing those types of needles might reduce their pain symptoms, decrease their pain avoidance, their fear avoidance, things like that. And here's, in Palo Alto VA, we are incorporating dry needling with ultrasound, which is interesting. So if you want to be more precise in regards to dry needling, you can do that as well. What you'll see here is dry needling of the iliopsoas. If you look on the slide on the left, you'll see a needle. It's a hyperechoic kind of pointy going directly towards the iliopsoas, and underneath is a more hyperechoic region, and that's going to be your lesser trochanter. When you go to the right, if you move your ultrasound towards the right, you'll see kind of like a blank space, and that's the femoral artery, and that's the area you're trying to avoid. Very cool. And here's an instance of one of our clinicians utilizing the ultrasound and at the same time needling. And as I near the end here are some quotes from patients. The big thing I want to point out is that, as Teo mentioned, we're in a special case where we work for the federal sector, and we have the opportunity to provide dry needling for California residents. So these are veterans and active duty that live within California that are able to seek dry needling because they are part of the federal system. And these are just some quotes from them. The next day, woke up feeling great for the first time in years. Experience instant relief in multiple tight, painful muscle knots. This has been the first treatment in 10 years of chronic pain that has worked. Just amazing. We also have examples of these patients who have wives or spouses that wanted dry needling, but they couldn't get dry needling here in California. So oftentimes you see them traveling or driving to Arizona, Nevada, things like that. Here's a leadership perspective from VA Palo Alto. At the time, this was our facility director, and he was a huge supporter and proponent of dry needling because he wasn't only just our leadership, but he was also a patient. And he's given us freedom to share this example. But there was, and he's fine with this. We have a document signed. He received L4, L5 laminectomy because of chronic low back pain. And I will say, I tried my best to make sure he didn't need the surgery. It was the last option. That's what our goal as physical therapists, right? We want to try to avoid surgical intervention. But anyways, he received surgical intervention, had an L4, L5 and laminectomy. And post-op, he worked with our acute care physical therapists. And after about 48 hours, there was no reduction in his pain. And so when you're in acute care, the first thing that your physicians and social workers are going to think about is, where are we going to put him next? We need this bed. And just from experience from working with me, he realized that he needed just dry needling to move better. So what the great thing is that we work collaboratively throughout a whole healthcare system at VA Palo Alto. The acute care physical therapist contacted me and said, hey, Jero, can you come take a look at Tony? I know you've been working with him prior to his surgery, and tell me what you think from your orthopedic background. And we took a look, and we didn't needle the L4, L5 area. That's not what was causing the pain. Actually, the pain was coming from his hip. And if you're looking at areas that are relative contraindications, that was a go. We ended up needling him in multiple areas in his hip, just inferior to the L4, L5 laminectomy. We were able to ambulate him for 100 feet immediately following, and he was discharged home that day versus forcing, I guess, the practitioners deciding whether or not to send him to a sniff. So that's kind of like the powerful effect you can see in regards to dry needling. And that's kind of an emerging area as well. We would like to see dry needling more in our acute care. We like to see it more in the ED. We do have dry needling in our emergency department at the VA. So again, we're avoiding patients becoming admitted for their MSK pain. Instead, they get dry needling and are sent home. We also have dry needling within our primary care. So when a lot of times, and we saw this with Rick's slide in regards to musculoskeletal expertise, a lot of times our patients will come into primary care and they'll come in with the MSK issue. And many times the primary care physician isn't sure what to do, right? And what you'll see in the private sector is they'll refer them, to physical therapy, Whereas we'll have physical therapists now in primary care that could immediately see this patient, and they might decide on the spot after their assessment, all you need is dry needling and HEP, of course, right? That's never a standalone practice, but what I'm trying to make is we can make a powerful impact in regards to dry needling.
And the one thing I just want to piggyback and highlight on that, I forgot to mention last time I presented, just to point out. So within our clinics and our healthcare system, they're not standalone PT clinics by itself. So it's very common in most of our clinics. There's a PT, there's an OT, we have chiropractor, acupuncturists, all work collaboratively in one clinic. So it's not a standalone. And as Joe mentioned, more often than not, we're all self-referring and triaging to one another. We might screen a patient first and realize, this is best served by you. Why don't you see the patient first, see if that you can make a difference? Or a lot of times, our acupuncturist or chiropractor will get the consult, but then refer to us, recognizing that this is more in your scope of practice. Why don't you see them first? And really what it comes down to, it's what's in the best interest of the patient. We're not going to try to capture everything. We feel like they can get better care or faster care to recover in their issue. That's more under a different discipline's wheelhouse. We have no problem triaging to one another. And so it's all recognized that we're all here to serve the patient, and their health is of what's most important. Whether we're the ones that get them to the finish line or someone else, it doesn't matter to us. It's, the patient needs to get out as soon as possible. And so we talk about a lot of what's in our wheelhouse. Like, for example, our boss, he's a PM&R trained physician who also does internal medicine, but he's been practicing acupuncture for 20 years. And we talk about patient case scenarios and what is in their scope and what they feel like we can do better. And we recognize that there's a difference in the technique and how we utilize the needle in terms of dry needling versus acupuncture. And so a lot of times we're just discussing different cases and why it might be better for us and them, but recognizing the way we approach it and the intervention we do and the tissues and the muscles we're attacking at are different than their approach. And we recognize that difference. But at the end, we're not trying to lay claim to the modality. We just want to get the patient better. And so we're just here kind of advocating that and on behalf of how we practice. And we're happy to take, questions from our experiences from the board as well as the community. Thank you so much.
Thank you very much. So I want to open up any questions or comments from the board.
Of course, I have a comment. I really appreciate how the two presentations complement each other and present information in a different way and experience in a different way. I'm not an acupuncturist. I don't understand acupuncture. I'm a trained physical therapist, a licensed physical therapist, and I followed the presentation. I understood what you said. I was able to follow along, and I'm comforted that the VA has a model, an interdisciplinary model, and when it's appropriate to refer to another discipline, including acupuncture and vice versa. And I think for me and probably many other licensed PTs, that is very fuzzy for us. And so, I would look forward to learning more about that in the future, and looking at your model and how that works, because we do agree, right? It's all about getting the patient better. You talked about initially treating pain, and now there are many more reasons why you would use dry needling and ultimately to improve function. But so many times that's the reason why we see patients is because of pain. And if they go to a physician, the physician might refer them to a discipline to work on a certain problem, but they are also maybe going to be prescribing medications, as you mentioned in your presentation. And obviously that's a huge problem, not just here in California, but nationally. And so I just would really like to see this modality become an option for physical therapists in California to help our consumers. I would really like the option to have it myself if needed. I'd like my family to be able to have this as an option, the consumers of California to have it as an option. So I really appreciate the information that you shared, and the success that you've had with it and the research.
Just a quick note, because we are patient care centered. I work on spinal cord, as you all know. The acupuncturist that I work with actually refers some of his patients to me. A lot of times he'll be working more systemic things, like high blood pressure or GI issues, but he knows because I'm there and because there's so many patients that we share or that we had that he can't get to all of them. So he will refer to me like, hey, Rick, this guy has this MSK thing going on, some pain. Can you address that for me? I'm like, yeah, of course. So we've learned to work together knowing that, he can utilize me because he can also, it frees him to see other patients as well, but he also trusts me to be able to address MSK issues for our same patient.
Yeah, additionally, at the VA, we do have employees who are also practitioners, and there are acupuncturists that come to us for dry needling. So, it's just a matter of getting well and feeling healthy.
Thank you. I had a couple questions and comments. I think our board member, Dr. Rubina Amin, because that is exactly what I pulled from your talk, which is the opportunity for collaboration and the fact that there are so many people that need care, and we can learn from systems like yours that have to address it in a way that is a shared responsibility. When we think about opportunities in the hospital, especially maybe post-operative or even where I work in pelvic health, postpartum, we have to break it up. There's no way that the physical therapist can do everything. There's no way that the occupational therapist can do everything in rehab, right? So recognizing that we all have different strengths and what we bring to it is very valuable. One of the questions I had was a little bit more on the effectiveness for the consumer and the benefits. Certainly, there'll be some patients that you said are contraindicated for whatever reasons. How do you see this for the majority of people that are not contraindicated or not precautioned, supporting either cost effectiveness or access to care? Could you speak a little bit more on that in terms of how it helps the consumer?
Yes, that's a good question. And I think that's the big point we're trying to emphasize is, the research supports that, when you utilize dry needling as an intervention, it helps, efficiency in terms of the system, in terms of getting patients improving their function and wellness faster. And so in terms of, healthcare systems are looking to utilize that effectiveness, your less sessions in a treatment area, or if you're losing it from a holistic approach in terms of patient bed care flow. Gerald mentioned, we have PTs in the ED. And so the main point of that is, in the past, a lot of our ED patients were coming in with acute flare-ups of low back pain. And traditionally, they'll go onto the floor to get admitted, to get an injection, to minimize the pain, and then sent out. But you're keeping a patient bed care. So why not have PT, treat them on the spot, discharge them home HEP, we can follow up in a week and mitigate them coming onto the floor so the hospitals can treat more sicker patients that need the actual bed care. So there's a lot of application to having this modality. I've mentioned, the primary care is a huge one that I know a lot of healthcare systems are adapting of putting PT in primary care, but obviously we would argue a PT with dry needling trained in primary care is even more beneficial because same time, we'll have patients come in for their primary care appointment, they'll meet the physician, it happens to be a low back pain flare up. They'll just call down to our clinic saying, hey, do you have time to come up to the floor? We have a patient that is perfect for you. Instead of us seeing them, sending a referral down, coming in a week or 2 weeks, and they're already in subacute pain versus the acute pain that we can address and have them come back and not even have to have a follow-up appointment. Or we can do a virtual care follow-up appointment and say, hey, I know we saw you a week ago. How you doing? Oh, I feel great. I don't need an appointment. Or if they did, then we can refer them for 1 or 2 more sessions. So it's, we see the benefit of it. And that's what I mentioned. And we have a researcher now that's going to go retrospectively to pull of our data. And we'll hopefully be publishing that in the near future to kind of share that with the world of how beneficial it is in terms of, obviously, the patient focus is what we care about, but also there's a benefit to every healthcare system to incorporate this there in California because it opens up more care, and access is a huge thing in healthcare nowadays anyway. So, I feel like we're kind of preaching to the choir, but yes, it's beneficial.
Yeah, and in addition to what Teo was stating as well, we also have to rely that physical therapists, we are the musculoskeletal experts. So we determine what's appropriate for the patient. Whether it's, if we're talking about number of visits that are appropriate, interventions, it depends. So perhaps one patient might need dry needling, maybe another patient does not. Maybe one patient might have the same type of issue, low back pain, may benefit from dry needling. Maybe they're going to benefit more from manual therapy. As PTs, we have to trust our clinical judgment and go along with that. So adding this tool to the toolbox will only just benefit the consumer more because we have that tool available for them.
And some examples, like especially with our patients who have functional issues, and a lot of it's included with their pain. There is such a big neuromuscular component or neurological component to dry needling, and when you are working with it, it's even for us when we first started needling, like all of a sudden, you have a patient who can only maybe abduct their shoulder to maybe like 80, 90 degrees, and then you end up hitting a few different structures, and they're at 100, 135 degrees. And you're like, whoa, what just happened there? And now they're able to functionally reach higher to be able to do things, and it's not painful anymore. A lot of patients that we've seen that who really complain of low back pain, then I'll go, well, wait a second, let's look at your posture. Let's see what's going on here. And it's usually from sit to stand, or like there's just at that last part of extension. I'm like, you know what? It's your hip flexors. We should really kind of address what's going on in the front of your body versus what's going back here. So all of a sudden you kind of loosen up the hip flexors here, and all of a sudden you're not getting that hyperextension on the lower, on your low back. And then you can also, engage your gluteal muscles much better, being able to, to improve gait. We have a few physical therapists who specialize in pelvic health, and we've taught a lot of our courses to other VAs that, were the pelvic health specialists, and it's great to talk to them. It's like, oh, it's very different than what, we're used to doing, but there are structures that we do teach in both courses. They have found very, very helpful within their practice, even just doing the abdominals, working on the adductors, to really kind of help out. So there's, it really crosses all different specialties within the physical therapy realm.
Piggyback on the question, did you all get trained obviously after in another state or here? I'm just trying to understand the background.
Okay, so we had a physical therapist who worked for the DOD, and he transferred over, and he asked us, he was like, you guys don't do dry needling here, do you? And we said, no, we didn't. And that's when Taylor was talking about, the crossover, like just, from having care as an active duty person to transition to a veteran. So we were actually trained by the US Air Force and for the physical therapists there. And so, we thought, well, we really weren't very familiar with it. And well, okay, this would be a great thing to have in our toolbox, maybe, whatever. But when we took the course, it was actually, wow, there's a lot of things that we are seeing here that, when you try to do range of motion to a patient, you're lucky if you can get 8, 10 degrees just doing the regular stretching. And when you can get another 30 degrees, not all the time, but sometimes it's like, wow, this is great. Now they have a new baseline we're able to, with stretching and their exercise program, to keep that. So we were trained by the U.S. Air Force Physical Therapist Program, and that's how our program was developed. From them.
Thank you. Any other questions, comments?
Just have a comment, actually, question, but this is very enlightening. Both presentations really provided a lot of insights. I heard about dry needling since I got involved with the board, and acupuncture was the first thing that came in mind. And this actually, the presentations definitely set apart using data, a different understanding of how acupuncture different from you guys. doing. And, I really, you refer to the integrated care model, really, and primary care is started using it as well. And I really see the benefit of that. It's not a matter of, the differences in applications, but what benefits the consumers. I think it's the most important, and it's all focus here also. And I consider different type of specialties, and if we can integrate it and then ultimately benefit the consumer is the way that I'm glad that you guys have a sort of a model that it's rolling out there, and that's something that it's very encouraging to see. Thank you.
Any public
I
comment?
have another.
Oh, sorry.
That's okay.
You-
I
you
just
want
two
to?
more.
Okay.
Teo, you talked about research, and I'm wondering if the VA is, or your group is actively working on any research that would be beneficial for the board.
Yeah, so actually, this morning we had our research meeting. So we're working on low back pain, our first kind of study that we're going to try to get out there and publish. We have some case studies that we've done like abstracts for, and we're going to be presenting this year at different conferences that we can share. One, it was a women's health one, it was a obturator internist dysfunction. And so we're happy to share whatever you want, but hopefully the plan, our strategic plan is over the next 5 years to have a lot more larger scale multi-site studies, publishing our information, because we're just setting up our database now with our researcher to retrospectively go through all of our cases, collaborate and collate all the different treatments we've been doing, and then we'll be pushing out a lot of papers. So as we do them, I'm more than happy to forward to you guys every time we do it, so you guys have it and can ask us questions about it.
Sure, thank you. I know Leslie presented some research in her presentation as well, and if you had any data to share regarding adverse effects, that might be helpful as well.
Sure, I mean, specifically within our system, yeah, we'll share it with you guys.
Yeah.
I mean, we've had no adverse effects
No.
so far in our healthcare system that, I mean, the people we've trained, but we'll continuously share with you guys as we do it.
That's great to hear. I think my last question would be, I know it will be anecdotal, but do you have any examples of patients that you have, California consumers who voice frustration at the inability to receive dry needling services in California?
Yes. We can't say that specifically maybe about our patients because they have the VA available to them, but definitely their friends, loved ones. Earlier I mentioned, some of them are traveling to different states just to get one treatment of dry needling because their partner was able to get it at the VA, and they're advocating for it for them because they know it could be beneficial for them to have. So, yeah, we can't say that about our specific patients because they have it available, but their loved ones and people they care about do not.
And within California, there are a lot of VA systems, but they are spread out, and not all the physical therapists in the VA do it. I mean, we are training therapists. We've been down to Long Beach, we're scheduled to go to other places as well, but they are spread out. And sometimes the ones coming from the Central Valley is like, do you have anyone closer to come see us? Well, we're trying to train, we're trying to talk to the other systems or try to get another practitioner who is dry needling trained to one of the clinics closer by. But I mean, some are coming in from Fresno or, Tulare, 3.5, 4 hours away just to get this treatment done. What's nice about it too, that we do have dry needling, practitioners, or physical therapists who do dry needling. So on spinal cord, I see a lot of patients for annual evaluations, but they come from all over because we're the hub. But I'm lucky is like, okay, well, you're from Lincoln. So you know what? I have a friend up at McClellan. I know 3 people there who are doing some dry needling up there that I think might help because, we do our evaluations. So you don't have to come see me in Palo Alto, but I can refer you to another VA clinic closer by. So it'll be more convenient for you.
these are Californians receiving these services in California, but not all Californians have access to these services.
If I were to piggyback on that, some of your VA members probably also have TRICARE. They get care outside of the services, and they might have come to you after seeing California therapists who are not trained or, oh, you want to share a message about? Okay.
Yeah, so the VA does offer something called community care. So if a veteran service member cannot receive care at a VA for any specific reason, they may receive care in the community. But there's been times where those patients have received dry needling, but can't receive dry needling out in the community in California because of the laws. So they end up, always coming back to the VA because of the care that we can offer.
Okay. Okay, and
Now I got a question now. So when you're talking about an access issue, when somebody who needs this type of services, and let's say they walk into your clinic and then you did that assessment, you sort of triaged and say, well, you need the so and so services. Is there probability or what's the process in terms of, referring them to acupuncturist to solve the same problem, or is that limited, or is that how does that workflow go?
So it's in simple, I mean, again, as PTs, we're musculoskeletal and functional, dysfunction, we look for that. So if, for example, a patient comes in and we do a full evaluation and we're not able to identify their dysfunction related to, muscle, joint, some kind of physiological condition that it's in our scope of practice to treat, we'll be transparent with them. It's like, I can't identify the source of your pain. So I'm not going to just do something for the sake of trying to do something. So we can call, our acupuncturist and say, hey, here's his history. Here's the background. This is what I'm seeing on my evaluation. I'm not finding anything, within our scope. What do you think? And then I go, actually, you know what? I think there's something that I can do for them because of X, Y, and Z based off their training. Okay, great. I'm going to refer them over to you. You can do an evaluation and assessment and speak with the patient if maybe there's something in your wheelhouse that can address them. Or for example, and if we refer to a chiropractor, maybe, the PT that's assessing them doesn't feel comfortable doing mobilization in a specific area that they're trained to do. They might contact the chiropractor. It's like, I think they have a dysfunction at this level. I think it really might benefit if they see you because I know you're a specialist in this area. Why don't you go down the hall and see them for your session instead of me right now? And they'll get a treatment, the proper intervention at the right time, and then they move out. So it's a lot of, nuances, but in the sense, as Gerald and Rick mentioned, if it's not within our scope, we're not going to just do dry needling because we have this tool and want to, use it or do some kind of intervention. It has to be something that we evaluate and it's in our scope of care to treat.
Is exactly what I wanted to hear. So thanks.
Okay, and on that as well, I mean, even though we've been practicing, and have dry needling in our scope of practice, and we've been practicing, individually for quite a while, doesn't mean we'll always use that. We have to make sure that it's appropriate. There's other things as well. I had a patient, or actually one of my colleagues had a patient who was having a severe headaches and also neck pain. And he's like, Rick, can you kind of look at his, cervical mastoids, his SEMs, because, I think he's getting the headaches from there. And I was able to palpate and we were able to reproduce the symptoms. But when you were trained in dry needling, there's certain procedures and how you may do it. And one of the things that we really look for is, especially around the, the cervical area, the neck areas to palpate, you have to find the internal carotid. And for this patient, I'm like, okay, well, let me find it, and I'm usually pretty good at doing it, but I couldn't find it on this patient. And I looked at him, I go, look, you know what? I feel an area that I can needle. However, I cannot clear your internal carotid artery. So what I want to do is just not do it, if that's okay with you. And he's like, yeah, that's great. So, there were times that, even as somebody, that has experience that, okay, well, this patient, it may help, but, there may be some factors and some, we look at our contraindications or even just surface anatomy, like, you know what, that is something that we need to really take into consider whether we're actually going to perform it or not. And there are times that I've declined it. So, we were looking at a patient safety.
So any other questions or comments? Everyone's good on the board? Okay. Well, I will now take public comment if anyone has any.
Hi, my name's, if I push something. Okay. My name's Paul Jones and I've been practicing physical therapist for close to 30 years. About 15 years ago, I heard about dry needling. It was actually through a radio talk show host out in New York. And he was talking about, oh, he's going to go to therapy and get dry needling. I didn't know what it was, so I kind of looked it up and it kind of piqued my interest. What's the difference between dry needling and acupuncture? And as the years went on, I started to have more friends that were trained in other states, as well as the VA. They said, oh, it works great. It's fantastic for the patients. It works better than electrical stim, ultrasound, whatever. So I kind of had a personal experience. With weightlifting, I hurt my shoulder. I did my usual things to try to get it better. It just wasn't getting better. So I made an appointment with an orthopedic surgeon. And of course, with healthcare now, it was 2 months out. So a good friend of mine who works for the VA, he's like, hey, do you want to try some dry needling? And I kind of pushed him off for a little bit. And finally, the pain was so bad and I wasn't really able to move my arm too well without pain. So I let him do it. After probably a 10-minute treatment, I was able to move my arm 60% better with maybe half the pain that I had. And I thought, okay, it's going to be, maybe a 30 minutes, an hour, and then I'll be back to where it was. Well, 4 or 5 hours later, I was able to have full range of motion without pain. So I went to go see the orthopedist. And of course, it's kind of embarrassing because now it's like the pain's minimal, my range of motion's better. So I talked to him and he said, okay, he says, well, what have you been doing for it? And I said, well, I had a couple dry needling sessions. And his eyes got huge. And he's like, you do dry needling? I'm like, no, we can't do it in the state, but I have a friend who does it through the VA. And he was trained in Texas. And he was just very interested. He was not so much interested in my shoulder anymore as looking at, hey, where did he poke you? Where did he put it? And so he was very, very interested. And I told him, I said, well, we're working on trying to get it legalized in our Practice Act. So he was very interested in it. It helped me an immense amount. I've heard nothing but good stuff. I've talked to other people who have taken the classes and stuff, and they talk about the contraindications and stuff and how they could lessen it. So the direction that the needle goes through, the palpation, and if you're not certain, then you don't do it. I think that's for many of our techniques that we do in physical therapy. If we're not comfortable doing it, then we don't do it. And then we refer out if we need to. Yeah, so that's kind of my personal experience. That's kind of a frustration for me as far as, I have friends, I have colleagues that have used this technique, and it's been very, very beneficial for their patients. And I would like to be able to have that access for us as well.
Thank you. Is there any other public comment? Okay. All right. Well, thank you all very, very much for your presentation. And I think we're going to take a short recess for 10 minutes. We'll come back 5 after 11. Thank you very much. Okay, thank you for rejoining us. We're continuing on the second day of the PT Board of California Board meeting in Sacramento, California. We are on agenda item number 17. We're going to start with Consumer and Professional Associations Intergovernmental Relation Reports with the Federation of State Board of Physical Therapy.
Hi. Thanks for inviting us here for this piece and letting me speak to that part. I know Leslie this morning was focused on dry needling with a lot of content on one of the resources that has been developed and maintained by the Federation. In lieu of presenting additional material on other types of resources that were available today, what I wanted to do is just use that as an example of the kinds of products that are available, resources that are available through the Federation to you on quite a number of different topics in different formats. Both the papers or the publications, webinars that are available on this topic and others, and through the hrri.org. The research arm, as Leslie referenced earlier, today there are more research that's being funded and published available. The most recent publication through HRRI that was released just in the last week is focused on reentry to practice, and specifically looking, if you will, at the atrophy of competency over time when away from practice from an academic standpoint. So that's another one that I would recommend. The other piece that we'd love to get some input on is the development, and I'm sure Jason has brought this back previously, but the idea of burnout, practitioner wellness, and the idea of healthy practice and the development of a healthy practice tool. HRRI has published research on the development of how to establish an effective assessment mechanism. And the Federation committees have been working on developing this assessment tool. The first 3 modules of the tool were previewed at CSM and are available. We'll be listing that out so that individuals can take it. It's broken into different modules so that a practitioner can go in and do a self-assessment. So it is considered anonymous because, of course, research shows that if somebody is reading your assessment of your own level of burnout or wellness and different elements, if somebody else is reading that like a board, your answers may be different than what you may answer if you are the only audience for that information. So that tool is being developed to be intentionally anonymous. However, it's being framed in such a way that a person can opt into having a certificate of completion generated per the modules that the committee is estimating are equivalent to about 1 hour of continuing education. So one of the questions that we're asking all the jurisdictions is, would your continuing education requirements allow for an individual to complete the healthy practice assessment tool, which we believe would be a benefit to them individually and ultimately to patient care, public protection? Is that something that would fall within the rules for continuing education courses that could be completed in California? Another piece that is a recent focus is there's a task force on animal PT, if you will, practice that is actively working. So if this is a topic that is of interest in California, the task force is looking at solidifying regulatory language and best practice. The task force that's been put together is made up of from the membership of Federation, PTs, PTAs, administrators such as myself and Jason, but there's also a veterinarian that is serving on that task force to really have a multi disciplinary perspective on that answer. I think what I'd really like to do is highlight the fact that since Jason and I are both administrators of our respective boards, this idea of through the Federation, through this membership-driven organization, we are each the 53 member jurisdictions that comprise the Federation. They are we are they. And from that standpoint, we lift each other up through that collaboration and through that sharing. As a board administrator, the ability to be here at your meeting and see your process it's a fabulous opportunity for me, because I am better at my job by seeing how my peers and my counterparts do things, and things that I can bring back and things that we can bring here. So that's my call to action. Not so much a presentation, but the Federation is made better by California's involvement on committees, on task forces. We do have a board member regulatory training that's coming up later in April. That if you haven't had an opportunity to participate in that, I would strongly recommend it, particularly for newer members, but also for individuals who maybe had been involved in those activities a couple of years ago, as a refresher. Because part of what you're doing isn't just didactic consumption, right? It's interacting with your peers across the country and discussing those trends and learning from each other. So please look at ways that you can do that. I'm so excited that you have this standing item on your agenda to talk about what's happening at the Federation. What I would love to be able to do is make it as much a two-way conversation. It is absolutely something that on a regular basis, if you let us know that issues of interest, as you did today, we can help locate in all of the materials ones that would be most relevant for whichever agenda topic is of interest. As your liaison, I'm happy to attend meetings when I can. If they're virtual, that can be more frequent on that, but that's something that we can do as well as Federation staff. One of the key pieces, though, is again, getting the input from you on what is the most useful. Because it's not enough to just have the collection of resources on topics that have come from the past. What is important is that we, as the community, as the membership, look forward to what's coming and make sure that we are developing those resources in the future. The next major group activity for Federation is, of course, the Leadership Issues Forum in July, where your delegate and administrator will be working with delegates and administrators from all jurisdictions, specifically on looking at those topics and identifying those leadership questions. And so one thing that would be very helpful to help prepare bringing California's needs, California's perspectives, California's expertise to that meeting is to begin thinking about that even today. And then at your June meeting, consider having a conversation or an agenda for your delegation to bring back and either present or inquire of the other jurisdictions. That, of course, in our annual cycle, if you will, the Leadership Issues Forum directly informs content through the rest of the year that might take the form of webinars available, but also leading into the annual education meeting. Specific topics or content or follow-up based on your needs and your leadership and your participation in the process. So with that preamble, what I wanted to do as your liaison is ask and listen to the things that are top of mind for you today, not to put you on the spot, but either today, if something comes up, or definitely through Jason and his staff to follow up with us, and we can get that queued up for your next agenda. So with that, I'll turn it back over to you.
Any comments or answers, questions.
Thank you for being here and for the report. It's a treat for our board to have you present. One of my questions has to do with the tool you mentioned regarding burnout. And I'm wondering if there is, after participating in the modules, an opportunity even for another CEU possibly for reflection and action plan. So not just to have taken the tool and be aware of what those issues are, but what are you going to do now, or what can you do now?
Thank you for that question. The tool is designed to provide those opportunities, and it does make recommendations on, similar to the board assessment tool, where you would take the assessment, but then it would provide resources based on your answers. The healthy practice tool works similarly. So there is a reflection, not really a score, but you know, a reflection back on. I know I've taken one of the modules, and my work-life balance is a little out of balance on that, which I was surprised. My family, not so much. But there were recommendations, research, readings, reflections. There's an opportunity to effectively journal. But all of that stays into a PDF in that session that you can then print, you can save, but is not stored on the system. And then there are the total of 6 modules. If you have time on your June agenda, by then they'll be fully released and could be demoed or a presentation. We'd love to bring that to you in June.
Thank you. Thank you very much. I think a second question is, there was a mention of a board website audit tool in past meetings, and I'm just wondering if you have any update on that.
I believe that has to do with sexual misconduct and information for the public and for licensees. There are some publications that are available that a board can, the underlying research for that is also located on the hrri.org website. There is a section for sexual misconduct and some research and some recommendations under there. But we can also be sure to send that directly to you.
Okay, thank you.
Any other questions or comments? Well, thank you, Michelle. One other thing that I really appreciated about getting to know the FSBPT's resources and Jason's involvement with the different committees was some of the videos and different types of consumer education pieces that are available that hopefully we'll be able to access through our relationship to help our consumers in California know what to expect and what to ask for, and when they are being treated appropriately in terms of physical therapy practice. Can you share a little bit more about any other types of products that might be supportive of us educating our consumers?
Absolutely. I think there are materials and committee work that is focused on understanding elements of the sexual misconduct, informed consent. So in addition to the website sort of assessment tool and recommendations on that, there are also publications or flyers that can be used with different audiences, including directly with the public. There are also similar publications that have to do with even what is physical therapy that can be useful for that audience as well. I think I would be remiss also to not mention that there's a recent video and webinar targeted at student PTs related to boundaries and sort of that transition and what to be aware of, because when you're in PT school, your sense of working, you know, in the lab classes with each other, that comfort level of interaction with them that can be different than when you're out treating patients, and the importance of that continuous consent And so that's another piece that I would recommend, given where we are today.
Thank you. Anyone else, any comments or questions? And take one from the public? Any public comment? Nope. Oh, hello, come on up. I think you can. Here.
Thank you.
Hi.
Good afternoon. My name is Dr. Michelle Lau.
Mhm.
I'm the president of the Council of Acupuncture and Oriental Medicine Associations, and also the president of American Alliance of Acupuncture.
Mhm.
First, I thank you for the opportunity to be here to meet everybody. And actually, I attended many times about this event before,
Mhm.
the COVID-19. But now I just make it short. It's like very important. I would like to ask all the member and to be consider what we're doing now today and talking the presentation of acupuncture. Yeah.
Ma'am, my apologies for interrupting. I'm Michael Canotes. I'm the board's attorney. Right now, we're taking public comment on the FSBPT report.
Yes.
There is an agenda item later for comments for items not on the agenda.
I just talking about the report.
Oh,
I'm sorry, the report that she just provided about the Federation of Physical Therapy State Boards.
Okay, thank you. So I just do it later on though. Okay.
yeah.
Thank you.
Number,
Yeah, thank you.
item 22 is public comment for
Okay.
items not on.
I'm so sorry.
agenda.
No, because I spent about 30 minutes to find the place after now, and I missed that. So I couldn't make any comment about that. But
Yeah, even though you missed that, you can make those comments during,
later on.
yes, for.
Thank you so
items.
much.
Thank you.
Thank you.
Thank you. Okay, is there any other public comment about item number 15? No, sorry, item number 17A? Okay. I would like to move on then to the presentation. Actually, if we could have the CPTA representative give her report. Could you introduce yourself?
My name is Daisy Defoe. I'm Executive Director for California Physical Therapy Association. Thank you for spending this time on the agenda. First, I want to say thank you to the board, to the Federation, and to the therapist department on that wonderful presentation. I'm doing. I've seen a lot of that information. I learned some new things, just pictures. So, but I really appreciate you bringing the issue forward and providing more detailed clarification, history, statistics. That's really for us and for the issue in general. So, that. Yesterday, we held our legislative day at the Capitol. We had more than 100 PTs at the Capitol to talk about issues that are important to physical therapy. We held more than 30 meetings in the building with legislators and more follow-up with the district. So overall, it was a really good day. We had a good turnout, lots of excitement. Our top priority still is modernization of the PT Practice Act. We talked about this before. And it would raise the Practice Act to the current level of education and training that is required for therapists. It covers a number of areas that are important to us. We do not currently have a bill. So it is still a priority. We are still promoting this, and it was our priority yesterday, as well as another bill we'll talk about. But just timing in the Capitol right now, an issue this big, we want to make sure that the timing is right, that the offer is right, time to devote to helping us push this forward. So we're holding off for the moment. There may be opportunities as the year progresses to bring something forward, but we'll likely be looking at introducing next year. Just an update on that. And a bill that we are working on for this year is prior authorization bill. It's AB 574, Mark Gonzalez. This is basically the same bill that we had a couple of years ago, AB 931, Jackie Irwin. This made it all the way through the legislature to the governor's desk and then was vetoed. It does still include that prior authorization would not be required for initial parole visits, medically necessary care. We still think this is an important issue. Like the legislators agree with us at the time, so we are bringing this back forward and hoping to be able to communicate with the governor's office and when it gets to that point and get something moving on that this year. The other bill that we're working on is AB 1009, school credentialing, again with Blanca Rubio. This is also the same bill that we pushed forward last year, which would create a pathway for PTs and OTs to obtain an administrative services credential. I feel like this is an important issue. This bill also made it all the way to the legislature, to the governor's office, and was vetoed. And we are hopeful, there has been some communication there. We are hopeful that this year the outcome will be a little bit different if we are able to get that far. There has been good communication issue as well. So that's coming forward and we will question on that progress. There is a bill this year for animal physical therapy. By the Animal Physical Therapy Coalition that would allow PTs to authorize PTs to authorize the licensed physical therapists for both an advanced rehabilitation and physical therapy to provide animal therapy upon the referral of a veterinarian under the supervision of a licensed veterinarian, and that the level of supervision will be determined by veterinarian. Our Government Affairs Committee met on Monday and reviewed a number of bills, including this one, and PTA has taken a support position on this bill. We are supportive of the efforts to move something forward in this area. It's been a long-standing issue, and so we are supporting this bill as it moves forward. Aside from legislative issues, I just want to remind everybody that our annual conference is going to be held in September 21st in Palm Springs at the Palm Springs Renaissance. We hope to see you there. Our education program continues to be strong, especially with our webinar Wednesdays, our CRPI courses. Our goal for our webinar Wednesdays is three courses per month, so that's 36 a year. And we did meet that and more last year, and hope to continue with that this year. A lot of great courses. And if you're unable to attend, they're on demand on our website. You can find them there. We will also are planning to do one in-person course this year. Those have been a little harder to get moving, just but we do have one planned for April 12th or 13th in San Diego, and it's mastering movement training and therapeutic exercise. And I think that's all I have as far as updates on the association. I do want to, along the lines of the webinar Wednesdays, I wanted to again thank Jason Kaiser for participating in our webinar Wednesdays last year. In August, he did the Q&A with Jason Kaiser. That was very popular. It always is. Every time we're able to get him to speak to our members and PTs who attend. So we're hoping that we can maybe get something like that on the books again this year. We'll be in contact. And then we always just want to say again, thank you to the PT board for the open lines of communication that we have with the board. We appreciate what we're able to do there and to collaborate on issues as appropriate and to really collaborate with the executive officer for questions that we just really appreciate that. Are there any questions?
Hi Stacy, good seeing you. What was that bill number that you said, Assemblymember Gonzalez?
That is AB 1009.
Thank you. Thank you.
I'm sorry. 574.
Thank you. Sorry.
Is there a bill number for the animal rehab?
AB 1415.
Thank you.
Any other questions, comments from the board? Thank you, Stacy. Any public comment for the California PT Association's report?
Hello, my name is G.V. Ayers. I represent the Animal Physical Therapy Coalition, and just wanted to make a touch base on that. Thank you so much for your report, and look forward to having the discussion with the board and also with the association as we move forward here.
Thank you. All right, thank you so much.
Thank you.
We're going to now get an update from Mr. Kaiser on DCA affairs and report.
Yes, I have a prepared update for the Department of Consumer Affairs. They would like to apologize for not being able to attend today, but as I get through the update, you'll see why that is. So the first update is based on fire response. Excuse me. On January 29th, Governor Newsom released Executive Order N1525, providing quick recovery relief for local businesses by deferring renewal fees and waiving other fees for DCA licensees in the Los Angeles wildfire areas. Specific DCA provisions include licensees whose license expired between January 1st and July 1st of 2025 will be granted a one-year extension to pay their renewal fee if their business or residence address is in certain zip codes impacted by the fires. Licenses will still need to renew their license, but their fees will be postponed for 1 year. In addition, duplicate or replacement licenses or wall certificates will be provided free of charge until January 7th of 2026, and delinquency fees are suspended until July 1st of 2025 for those that are impacted by those fires. DCA met with Board and Bureau leadership on January 29th to discuss the executive order and its implementation. DCA provided messages to the boards and bureaus for dissemination to the impacted licensees, as well as consistent messages for use on all board and bureau websites. Boards and bureaus have shared the executive order and fee deferral opportunity with their stakeholders. We sincerely appreciate the quick and personal outreach by the boards and bureaus to impacted licensees. Each DCA board and bureau website was updated with information for individuals impacted by the fires. DCA's Office of Information Services, DCA's IT team also developed landing pages for all online databases, so those going through the renewal process will receive information regarding the fee deferral when they go to renew their license online. DCA has also dedicated Disaster Help Center webpage accessible at www.dca.ca.gov that includes information on the executive order, FAQs, and other important resources that may be helpful to licensees and survivors as they navigate the rebuilding process. Additionally, DCA has a toll-free phone number, 1-800-799-8314, and an email, cafires@dca.ca.gov, available for fire survivors needing assistance. We're grateful to the governor for this opportunity to assist our licensees in their time of unprecedented need. A special thank you to DCA Board and Bureau leadership for their continued partnership and commitment to help survivors. The next update is on the governor's 25-26 proposed state budget. Governor Newsom released his proposed state budget on January 10th. Additionally, DCA's vacancy reduction and government efficiency plans were approved by the Department of Finance and may be made official in the spring revisions. The governor remains committed to funding resources to address California's housing and homelessness crisis, including in the governor's proposed budget is the creation of a dedicated California Housing and Homeless Agency. The Department of Consumer Affairs and other regulators currently under the Business and Consumer Services and Housing Agency would form a separate agency called the Consumer Protection Agency. This is an extraordinary opportunity for DCA to better align with other consumer protection entities as one consumer protection agency. With a Consumer Protection Agency secretary with the governor's cabinet, this is an exciting opportunity that will only strengthen our mission, momentum, and delivery of services to California. The governor's reorganization proposal will be reviewed by the nonpartisan Little Hoover Commission and the legislature this spring. And as more information is available, DCA will continue to keep board and bureau leadership updated. The next topic is hybrid telework transition. On March 3rd of 2025, Governor Newsom issued an executive order requiring all state agencies and departments to update their hybrid telework policies for employees and increase from 2 to 4 days in office per week beginning on July 1st of 2025. On March 13th, the California Department of Human Resources issued guidance on implementation of the executive order. The guidance provides defined parameters for when agencies and departments can make case-by-case exceptions to the 4-day in-office minimum requirement. DCA is working closely with the Business Consumer Services and Housing Agency on its next steps and will be meeting next week to discuss this transition with board and bureau leadership. The next update is Board and Bureau Relations Team Update. Yvonne Durantes served as the Assistant Deputy Director of Board and Bureau Relations since October of 2022. And on December 6th, the governor appointed Yvonne as the Assistant Deputy Director of Legislative and Governmental Affairs at the California Governor's Office of Emergency Services. Yvonne's last day at DCA was December 31st. Melissa Gear was also appointed by the governor as Deputy Director of Legislative and Governmental Affairs at the Department of Healthcare Access and Information on February 14th. She has been with DCA since September of 2022, and her last day with DCA was February 28th. We appreciate their dedication to the department and wish them well in their new roles. And ongoing, should you have any questions or need assistance, please continue to contact DCA at memberrelations@dca.ca.gov. Those are the two vacancies that would have been providing this update today if they had not moved on. So in closing, thank you to board staff for their continued hard work. And thank you, board members, for your dedicated service on behalf of California consumers. Sincerely, Christine Lawley, Assistant Deputy Director of the Department of Consumer Affairs.
Thank you. Are there any questions, comments from the board for DCA report?
I was wondering if you could provide any comment as our EO regarding the reorganization of public protection?
So as a board, we are under a larger department of the Department of Consumer Affairs, which is under a larger agency, Business Consumer Services and Housing Agency. And the proposed plan by the governor is to take the existing agency essentially and split it into two, creating two separate agencies, one focused on housing and homelessness. And essentially the other boards that don't fall into that category would then fall into the larger category of Consumer Protection Agency. I think it is an opportunity to kind of rebrand, if you will. I think that the longstanding title of Department of Consumer Affairs is not quite as clear as the Consumer Protection Agency. So I look forward to that. And having an agency secretary that is their sole focus as consumer protection may be beneficial to all of the boards underneath the department as well.
Thank you.
Any other questions or comments? I have one. I think this is appropriate time because they're not here, but it is their section. How is it looking for our appointments? Can you give us an update on our vacancies on the board?
Probably not any more than I touched on in my executive officer's report. I did have a conversation with Christine Lawley this morning. Again, she was apologetic in not being able to attend today. They are a little spread thin and there are other more meetings. And I don't think they thought the travel to Stockton, or at least they planned for it logistically. For appointments, I've been assured that they are aware, and when I say they, I mean both board and bureau relations, but also the governor's appointment secretary of our existing longstanding vacancy since 2023. And they are also aware of our more relevant and pressing vacancies coming up as of June 1st for both Dr. Alicia Rubina Amen and Katerina Ellaby. So we have 3 potential appointments, all happen to be governor appointments. And they are aware. And, you know, as I touched on the executive officer report, I have seen a number of Department of Consumer Affairs appointments made since our December meeting. But I would also say that California has gone through some trying times over the last, 5 months with the SoCal fires. And I think we're even seeing those impact legislatively in this session, the reduction in the number of bills available, and some of those bills being or addressing directly the wildfires and relief. So I can only imagine that the governor's office is under that same kind of pressure. But we are very much looking forward to filling those vacancies.
Thank you. I just wanted it on the record one more time in another location on our message. All right. Are there any public questions? I mean, public comment for the DCA report? Okay. Not hearing any. We're going to go to
I would take it out of order.
So before we go into our unit reports, we would like to take number 22, public comments on items not on the agenda, to give an opportunity for people who are here to speak.
Thank you so much. So again, my name is Dr. Michelle Lau, President of the Council of Acupuncture and Oriental Medicine Associations, and also the American Alliance of Acupuncture. We both is for California and the nationwide. And our office will be in Sacramento and also in Washington, D.C. What I concerned the more is like, I put in very short because I know your time, okay? And first of all, I concerned is like for the public protection, but actually I want to talk, but now I say I put it together to say when I try to talk to Mr. Kaiser. What happened is in California, we are already facing a lot of big change because the federal law now is already passed the acupuncture into the CMS Medicare system and on 2020 and January 20. But now for 4 or 5 years past now, we're working really hard to put licensed acupuncture into the system can serve like a 6 or 70 million of the elderly, which we're doing very well. And we practice the acupuncture clinic inside the Congress since the 4 years ago. We go every month and let them know how does acupuncture work and how effective it is. And I'm going down there every month since 4 years ago. So I try to say that this acupuncture profession in this country, in California, is over 50 years old. And now our practice education required is like a master degree, at least 3,000 hours. And the doctoral program now is approved by education department. It's a 3,535 to about 4,000. Every school a little different. But in order to get into the doctoral program, and now we have many schools already have doctor degree. And now I consider is that we're very happy to hear the physical therapists, they really like to practice dry needle, actually part of the acupuncture. In California, any needle you perform into the bodies and then consider is acupuncturist. The scope of the practice. So anything insists that, except that is illegal. In California, I know that about 5 states now is prohibited to don't do it. And I just heard five states is not, no comment. But unfortunately, many states, they practice the dry needle and then they say dry needle better. Actually, it's acupuncture. But the other state, they are not strong as California. California, we have very, very good law and make sure what the education and the acupuncturists when they learn, not just a few hours or 100 hours or even less, okay? And we require the, actually I request the board of the physical therapists and really put attention on it to protect the California consumer, the health, and everybody have to know when they insert the needle, just relieve the pain. It's so complicated. You have to learn the theory, you have to learn the practical examination, go through all the practice, you know. And the last, I just hope, okay, acupuncture becomes so welcome and so demanding now, and even though in the system, like we go to DC every month, 1 or 2 days practice inside the Congress, and really want to prove that different people come in for different problem, headache, you know, the whole body or something else, we can treat them. And just within about 20 or 30 minutes to let them feel the differences. So again, so protect the California acupuncture profession, and so also mainly is protect the consumer, our patient. And we have to be very, 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 very straightly to have a good training, good education before they go to insert the needle into the body. Again, dry needle is acupuncture. It's part of the acupuncture and then long times already. Thank you so much.
Thank you. Is there any other public comment on items not on the agenda?
Good morning, board members. This is on. Are we good?
Yeah, try the other one, Ben.
Good morning, board members, board staff. My name is Benjamin Bodia. I'm the executive officer for the California Acupuncture Board. My role is not to discuss modalities, efficacies, and treatments. My role is public protection, just as your executive officer, Kaiser, is, as is his. I just wanted to be clear for the public. I feel this board has been doing a good job and the board staff has done a great job in terms of enforcing our respective acts. As we just heard from the public, needling in California is clearly defined in the Acupuncture Act as the act of needling. And so the board does see any form of needling as needling. And I don't believe there's any contention with that. So I just wanted to affirm that we are sister agencies. Our purpose is public protection. We leave it to the professions and the public and the legislatures to address any additional modalities that each profession should be in charge of. I am also available for board and board staff for any additional questions and continued collaboration. Thank you.
Thank you. Any further public comment?
Again, my name is G.V. Ayers. I represent the Animal Physical Therapy Coalition. Coalition's president, Karen Atlas, could not be here today, so I'm making just a few comments here in her absence there and that. The Animal Physical Therapy Coalition is a coalition of representing veterinarians, physical therapists, registered veterinary technicians, animal welfare rescue organizations, search and rescue, military canine handlers, and obviously the greater animal loving public. Coalition is dedicated to increasing safe access to animal healthcare options, specifically authorizing California licensed veterinarians to refer animal patients to qualified animal physical therapists for treatment. This year, Assemblymember Wallace has introduced AB 1458 to allow for interprofessional collaboration and increase safe access to animal PT services. And that bill is currently in spot form now intent language, but language has been submitted that would fill that out in greater detail. We have submitted a letter to Mr. Kaiser requesting that an item be placed on the board's June agenda for us to give a presentation regarding what animal physical therapy is and have opportunity for exchange and discussion question such as that as well. And we look forward to hopefully a positive reply to that request there. So that's really all I have to say. I didn't know if that was to be said now under
Perfectly
this or
fine.
later under the other, but anyway, I wanted to just take that very much and appreciate your time and the opportunity.
Thank you. All right, any more public comment on items not on the agenda? Number 22.
Hi there.
Hello.
My name is Nick Sullivan. I'm a student here at University of the Pacific. I'm a little terrified to do this in front of the board, but I wanted to speak toward, unfortunately, I missed the presentation on dry needling, which is something that I'm very curious about, as I've heard a lot about it, but not had a lot of didactic learning on the subject. I look forward to seeing that online later. I just wanted to speak more from an anecdotal student's perspective, as this is something that I encountered in looking for PT schools in California. But in my search for PT schools, I found that many schools in California don't really teach dry needling because it's not allowed in California. And if they do, it's a very brief blip on the road to other lessons. I'm a non-traditional student, so many of my other friends and mentors who I graduated with in undergraduate school, they have told me that they greatly use it in their practice. And I feel a little bit frustrated that I can't learn about that. Dr. R.A. is one of my professors, and she can probably tell you that I'm very driven and very curious. And so that frustration comes from a lack of having access to those skills in a traditional didactic method. Yeah, and I just wanted to express that. Thank you for your time. I really, really appreciate having this opportunity to see how the legislative side of things happens. And I think that this is a fantastic opportunity. And thank you for your time, board members.
Thank you. Any further public?
And ask the board have any question, because after my my speech, I just have opportunity if you have a question from the board regarding the dry needle from the physical therapist and also related to this issue.
Yeah, we don't engage in discussions with the public during public comment. So thank you
Okay.
for your comment.
All right, I just asked a question, ask you guys. Thank you.
Thank you. Are there any other public comments? All right. We're going to then move on to our reports from our administrative services unit.
I think I can do this one really fast. So I'm going to be reporting on the administrative services report. You have the briefing paper and the materials regarding expense and revenue. There are a couple key items in there, but a couple updates that I'd like to provide on behalf of Liz Constanzi, who's the manager who could not make it today. Two things, well, essentially maybe three things. One is just kind of the current state of the economy. So reporting on travel right now is status quo. Travel's been reserved for mandatory requirements such as board meetings, training, and education. Speaking of training, that is also status quo. Travel has been limited to job required training, and we are utilizing DCA's solid unit for our training needs. And we'll continue to explore options for training that is not job required and not offered by solid, but as of right now, we may be fiscally refrain from doing that. And to date, PTB staff and members are in compliance with their mandatory training and reporting requirements. So thank you all for that. The PTBC has authorized 29.1 positions. And as I kind of touched on in the executive office report, for quarter 2, we did have 3 vacancies and we made 2 appointments during that period of time. One to our licensing service unit with Andrew Caton, and in the enforcement unit, James Heaton. And the admin unit has recently filled its lead analyst position with Anastasia Stokes. We do have one other vacancy that we are very close to filling. And as I mentioned in the executive office report, we have a new vacancy in the application and licensing services unit. Looking into the budget items of the report, you'll see that the Physical Therapy Board has authorized $7,139,000 this fiscal year to support program requirements, which include personnel services, operating expenses, and equipment. And as previously reported, there was a decrease in our budget authority of $378,000. Those adjustments, primarily in personnel services, did increase from $3,509,000 to $3,645,000 to cover workmen's compensation, benefits, and retirement costs. But our operating expenses and equipment decreased from $4,107,000 to $3,593,000. The PTBC has experienced additional adjustments through the GALI process. GALI occurs during October, December before the governor's proposed budget is introduced on January 10th. The budget authority would be adjusted to align with the Department of Finance budget worksheets prepared through the Budget Act. For example, the PTBC historically would have different budget allotments for different line items within each area, department services, both internal and external. However, some of those designated budget allotments were combined altogether into one category rather than different line items. So we are going through some restructuring. What we're looking at now essentially is bottom line baseline budgeting. For quarter 2, for expenditures, as you'll see, we spent $1.8 million roughly, and $3.9 million year to date for a good halfway mark. And we are living within our means, collecting revenues at the end of quarter 2 of $4.3 million. So we have spent about 55 of our total budget allotment. We typically like to be at 50% at the halfway mark. However, 56% increase in expenditures for the Office of Administrative Hearings and some enforcement costs that I kind of described during my executive officer's report, and additional expenditures for the onboarding of new employees, such as equipment. We have directed internal caps and general expense to accommodate some of those changes, and we'll continue to monitor any necessary changes that need to be made. Currently, our fund condition is projected at 8 months reserve for current year. It does dissipate with very conservative estimates to 7.1 months in budget year 25-26. But those numbers will change as we close out the fiscal year in July. If there's any questions that I can answer, happy to.
You mentioned the equipment expense was for new employee equipment?
New employee equipment. And I think what you're referring to in the budget line is an excess of planned budget. You might remember in the previous fiscal year, in the third quarter, we did receive an executive order to restrict purchases to a bare minimum. At that point, we had a large order placed for replacement laptops because our laptops were at end of life. We were not authorized to collect those laptops in the end of that fiscal year. So when the fiscal year changed and we went back to our new budget allotment, I believe it was $8,000, we actually paid the $60-some-odd thousand bill for those laptops. So it's just a displacement from one fiscal year to another.
Thank you.
Jason, how many laptops was that?
33.
Any other questions, comments from the board?
It's more of a comment, actually. Thank you for including that fund balance roll forward. I know Dr. Amman is very happy about that.
Yeah. I agree.
Yeah. And I do have one question regarding the equipment was one of the things that I was going to ask. Roy, regarding the salary budget, the reason that we're not, there's a budget cut, but it didn't impact our positions because we had vacancies, and so it didn't really cut into the available dollars to cover those.
So there were actually two drills that occurred simultaneously.
Okay.
And one was an 8% direction and overall reduction of the budget. The second drill was what we call a vacancy sweep. And that was an assessment by the California Human Resources to look at existing vacancies and if they were vacant, to essentially sacrifice them to the drill. During that drill, during at least the period of time that the drill was conducted, we did not have vacancies that fell, that weren't considered mission critical, that would be subject to that drill. So we didn't lose any position authority. But to your point, budget authority and position authority are two different things, but they're often attached. Sometimes they're not. Sometimes if you go through the budget change proposal process and you're seeking new position authority, and you already have the money in your budget, they might just give you the position authority, and then you have to make an internal decision on how you're going to fund that. But through the budget change proposal, more often than not, monies are attached to that budget authority. And those monies include both the salary for that person, but also all of the overhead costs that might be attributed to that person, square footage, space, equipment, those kind of things. Also retirement and benefits. So while we did have to reduce our budget by that 8% as part of the drill, we didn't lose position authority, and we haven't sacrificed any of the vacancies. We've been able to continue to fill those vacancies. That 8% cost savings has been realized in other areas through internal caps.
Thank you.
Are there any other questions, comments from the board?
Just one point to make about the equipment. 33 laptops, but also the ancillary devices, the docks that go with those laptops, the external monitors also. So it's not just the laptops.
Okay, any public comment on the administrative unit update? Nope. We are going to then move on to number 19, licensing services update. Kearney?
Good morning, or good afternoon by this time. Bear with me just a moment here. Well, in February, DCA implemented a program to give relief to the wildfire victims in Southern California from the Palisades and Eaton fires. And what they were doing was eliminating renewal fees or delinquent fees for those whose licenses expired between January 1st of 25 and July 1st of 2025. We had a list of approximately 100 licensees from that area, and we contacted each of them both by phone and by email. We left messages if we could not get in touch with them. I can't say that we had a huge response to that effort, but it did, but at least we reached out and gave them the opportunity. They could also, if they're for PTs Their wall certificates were destroyed in the fires. We were replacing those at no cost. I personally worked with a couple of PT licensees with that, and they were very grateful, I would think. So it was a good effort. And overall, licensing services, application services, initial license applications received increased by 12% from the same 2 quarters from last fiscal year, with PT applications received up 8% and PTA applications up 24% overall. USA educated PT applications received increased 11%, and PTA applications received increased 28% for the same 2 quarters. Of the 1,455 initial applications received year to date, 94% were US graduated, with 71% exam applicants and 29% were by endorsement. Foreign educated and military applications were 6% and 3% respectively. Initial license applications processing times, applications received to license issued or application closed for US graduates averaged 29 days, while foreign educated applications processing times averaged 50 days. Military applications averaged 8 days, and this data is for applications completed during that time frame. The target turnaround time to license issuance for US graduate complete applications is 45 days for applications by endorsement and 90 days for new graduate applications. And just a side note, we're doing really well in applications. We've become very streamlined. I dare to say efficient. Currently, we are acknowledging receipt of the application in under the 35-day required time. It's averaging around 2 to 3 weeks, which is really good. And also, we have a new report. I don't have it here with me. It's being vetted. That shows that with more updated data and shows that for Q2 of this year, for all applications types, including foreign, whether the application was complete at received or incomplete at received, it was 55 days processing time. So at this point in time, and that can change with the influx of new graduates about to appear, but at this date in time, an applicant could expect to have their application completed within 60 days of being received. That's pretty impressive.
Yeah.
Yeah, I'm really proud of the staff. They're doing great. Any questions?
Yeah. Just for my own information, really, I suppose, and anyone else who's interested, you said something about 2 weeks to receive an application. Was that the correct?
Well, once they submit their application, the submitted date is the date that they would submit payment. Okay, so once that application is submitted, we're supposed to acknowledge it, let them know that it's officially been received within 30 days. And we are currently running between 2 and 3 weeks for that.
So that's
license type.
okay. And that is just receiving an application, not even looking if it's complete, incomplete?
No, not the evaluation, just the acknowledgement that it has been received. But that's the first step. And if we get backlogged, that's going to be the one that we really have to work on to get it under that 30-day turnaround time.
Okay.
So we are at that, we are under that currently without any drastic measures.
What does it take to acknowledge an application? What's that process like?
We put a message in the Breeze account.
Yeah.
Any other questions or comments? I wanted to also acknowledge that the website was updated with that information about the fires and
Yeah.
and I love that. I love the fact that we're that quick about it and you had such a intentional effort to reach out to those that might be affected.
Thank you. I
So,
appreciate it.
thank you. Any other questions or comments? Okay, any public comment on the licensing services update? No? Okay, I would, no, thank you. I would like to take this time to break for lunch. We will be returning for the remainder of the agenda at 1 hour from now, which is 1:15. Thank you for your participation. Okay, welcome back to the Physical Therapy Board of California board meeting in Stockton, California, day 2. We are coming back from our lunch recess and we are going to resume the remainder of our agenda, starting with item number 20 under Consumer Protection Services Update. Ms. Phelps.
Good afternoon. Thank you for saving the best for last. My name is Carol Phelps. I'm the manager of the enforcement unit, also known as the Consumer Protection Services Unit, or CPS for short. In Q2, the CPS unit filled its vacant analyst position and is fully staffed still in Q3. Our newest analyst, Jim Heaton, is picking up quickly on the enforcement processes and now has a full caseload. Currently, there are 463 complaint cases being investigated by 6 analysts. These cases are all at all stages of the investigation process, from complaint intake and desk investigations, DFI investigations, expert review referred to the Attorney General's office, and even some in compliance monitoring for administrative citations and public approvals and reprimands. The CPS unit and PTBC management continue to hold meetings at least quarterly or more often as needed with our contacts at the Division of Investigation and the Attorney General's office to discuss outstanding issues and to collaborate to ensure effective case and program management. Additionally, PTBC continues to work with both DFI and our liaison at the AG's office in planning the 2025 schedule for the investigator and expert consultant trainings. The CPS unit has transitioned to PTBC's SharePoint site for all electronic document storage. And thanks to our IT guru, Vincent Azar, we have quite a few new tools and automated reports that help streamline some of our procedures and assist us in our efforts to efficiently process complaints. Vincent has been working with staff and management on ideas for more SharePoint workflows that will simplify tasks, create more uniformity, make timely information available, and just streamline our internal procedures. As staff becomes more familiar with SharePoint, additional ideas for workflow improvement will continue to be reviewed and implemented on an ongoing basis. Referring to the statistics report for CPS, this is Q2 of 24-25, so October to December. Performance measure 1 for intake shows that we received a total of 134 cases this quarter, including 86 consumer complaints and 48 reports of arrest or conviction. This is slightly fewer than we received last quarter, but overall 8% more complaints have been received so far this year compared to this time last fiscal year. Performance measure 2 measures the average number of days after receipt until the board initiates a case and sends an acknowledgement letter to the complainant. Our average is 3 days to complete this, and with the target being 9 days. Performance measure 3 shows the average of case age in days for all cases that did not result in referral to the Attorney General's office for formal discipline. The average case age was 169 days, which is 28% higher compared to this time last fiscal year. These numbers do reflect the average aging of all cases in this category and include the entire investigative process from intake to final outcome. Again, just for cases that do not result in referral to the AG's office for discipline. Our target for this performance measure is 180 days, so we are currently meeting this target. And performance measure 4 captures the average case age in days for cases that were referred to the Attorney General's office for formal discipline. 12 cases were finalized at the AG's office this quarter, taking an average of 685 days from receipt of complaint to final outcome. The target for this performance measure is 540 days. With a small number of cases reaching this level of administrative action and with the complexity of the type of cases where discipline is taken, the average for this performance measure can vary widely from quarter to quarter. For example, in this quarter, 6 cases, or half of the cases closed, took longer than 2 years to complete, whereas last quarter only 3 cases each over 2 years. And just that small number of cases, your average is going to vary widely. So in summary, this fiscal year so far, staff has initiated 292 new cases, issued 14 citations, completed 228 desk investigations, referred 29 cases to the Attorney General's office, received 1 interim suspension order and 2 PC 23 orders, and closed 22 cases after referral to the AGs. Do you want me to tell you what those mean, the PC 23? A PC 23 is basically Penal Code 23, and that's when the board can intervene in a criminal matter and request the judge order license, either suspension or some kind of restrictions on a license during the pendency of criminal law. So we had 2 of those issued in the last quarter. So the attachment B is a discipline summary for the quarter. In this quarter, 1 public letter of reprimand and 1 public approval were issued. 5 licensees were placed on probation and 4 licensees lost their privilege to practice PT by revocation order. And just a quick note, a difference between a letter of reprimand and a public approval. The public letter of reprimand, and I believe it's 2660.3, Jason, I'm pulling this just kind of,
So
that's an internal, letter that we issue in lieu of sending a case to the AG's office and filing an accusation. We can do that prior to that by issuing a public letter of reprimand. A public approval is where the result of a disciplinary action where a case was sent to the AG's office, an accusation was filed, and either we stip to a public approval, which is a disciplinary action with no probation, or it happens through the hearing process. Thank you. That's my report. I'd be happy to answer any questions.
The PC 23, you said you had 2 of those?
Yes.
And how frequently do we see those?
It varies. I think 2 is kind of it's an average number. We could have quarters where we do none.
Yeah.
It just kind of depends on what criminal action's coming through for our licensees at any given time.
Yeah.
And these are instances where the criminal behavior is so concerning that with the idea of public protection in mind, we're asking a Superior Court judge to essentially suspend that license's ability to practice while we go through the rest of the administrative process. So 2 at one time, I think is somewhat unusual, but 1 a quarter is probably kind of an average for you.
Thank you. And I'm wondering about the quarterly meetings you have with AG and DOI, and if you can speak to the fruit that comes from that.
So we have those meetings kind of as needed, but we're trying to have them at least on a quarterly basis, so we stay in touch. Sometimes it's a matter of just kind of getting together and comparing notes on caseload. If we have a case where there's a specific question or a concern regarding either how the investigation's going or what we want done, we'll talk about that. We have talked about the investigator training with DOI at those meetings. Generally just kind of an update and case review, just kind of comparing notes, how everything's going. DOI will come to us with suggestions of our processes. Like one of the trainings they offered was how to submit an RFS, a request for service, and how to do that most efficiently. We talk about that at our meetings, and just kind of how to improve so we all can do our jobs a little bit better, just generally. Same thing with the AG's office. We'll often come with we don't share specific case information, but some specific cases will come up with questions that are about the legal process. And the DAG can answer those questions for us.
Thank you.
It can also give us an idea of AG resource issues, DFI resource issues, and vice versa. Sometimes we're able to share with them. Carol, thank you for sharing the statistic of just how many cases are pending versus, the 6 analysts, right? So I think that some of you might remember me mentioning this on some numerous occasions and some maybe few. I think for us and caseload wise, the complexity of the cases, the sweet spot that we're looking for is about 50 cases per analyst. And right now we're at about 75 cases per analyst. So it's something to keep in mind when we're talking about resources in the future. and discussions even with the AG and DFI.
Any other questions or comments from the board regarding this item? I wanted to also mention, looking at the transmissions to Attorney General, it looks like our target dates, I mean, it's 5:40, right?
Yes.
And of the parts that are related to us, is that the intake and the pre-AG transmittal?
So the parts attributed to the board that are not attributed to the AG's office are intake, the PM4B, which is investigation only, and then the pre-AG transmittal. The intake is really just that 3-day period that it takes us from receipt to initiation. And the pre-AG transmittal, that's usually just, most cases are 1 day for that, because we basically close our investigation when we send it to the AG. There's some cases that go longer than that, that skew that average a little bit, because we may, for example, if we deny a license, they have 60 days to request an appeal.
And you add that
So
in.
we denied and closed the investigation, but then, so that one case may throw off that average. So most cases are 1 day for those. The PTBC part of that is really the investigation only. And that we share that with DFI too. So there's that 301 days is board and DFI investigation.
Okay. And the post-AG is not, when we send it, does the time stop?
The case age does not stop until the case is closed. So that post-AG transmittal is from the time we submit it to the AG until the final decision is reached.
Got it.
There, for the purposes of measuring for performance measures, there have been many attempts to try and create kind of like a chess clock process, if you will, where we can say in our control or out of our control.
Like our license.
If it were, well, similar to the application process, though, if it were that simple, right? So even in, once a case has been sent to the AG, you might receive feedback from the AG that further investigation is required. So that clock is still started with them. Yet there's still a collaboration that occurs with PTBC and the DFI, and even sometimes local law enforcement agencies. So the numbers can, they are worth what they're worth, right? There's a little bit more detail to them, which is why we try to break them down a little bit farther. So you can see essentially what statistics might be skewing those averages.
But in general,
The AG, the time at the AG includes the time from, so from the time the AG receives it to the time an accusation is filed, that's really on the AG. But from the time an accusation is filed until the time a final decision is reached, kind of everybody's involved in that process, because you have to get OAH to schedule a hearing. You've got to get response from the respondent. You know, they've got to participate in that process. So there's a lot of back and forth during that time. And oftentimes you will schedule with OAH and automatically you're adding 6 months to even more than that to the time frame, because right now in March, they're scheduling hearings in August, September, you know, sometimes things like that. So there's a lot of variables in that last number.
Yeah, even in scheduling the hearing, that could be further exacerbated by respondents asking for a continuance for cause or that kind of thing. So
thank you. Any other questions, comments from the board? Okay, any public comment on this item? All right, thank you again. And we're going to be moving on to 21, probation monitoring services update by Mr. Merton.
Good afternoon, everybody.
Hello.
My name is Monty Martin. I'm the probation monitor for the board, and I'm here to report on Q2 of fiscal year 2024-2025. During the second quarter of the 2024-2025 fiscal year, the number of licensees on probation decreased from 71 to 66 licensees for various causes. Besides the 47 licensees on probation and actively working in the state of California, there were an additional 7 out-of-state probationers tolling or not receiving credit toward completion of probation, and 12 in-state probationers who were tolling due to unemployment or underemployment, where they were not able to work more than 192 hours in the quarter. 5 licensees were placed on probation in the quarter, and 5 licensees completed probation. 3 licensees were revoked, and 1 licensee voluntarily surrendered their license to the board instead of facing possible disciplinary action. Of the 47 licensees that are not tolling, 10 are enrolled and participating in the board substance abuse rehabilitation program, equaling about 21% of all licensees on probation that were not tolling. 3 licensees enrolled in the substance abuse program in the quarter, and 1 licensee completed the program. And just a side note on the board substance abuse rehabilitation program, the vendor for that program ended their relationship with the board. They did not vote on the new contract or bid to be the new contractor when that contract ended. So we now have a new vendor for that program as of January 1, and that's Premier Health. They're now operating, like I said, the rehabilitation program. There's a few hiccups when they first took over at the beginning of the year with staffing and kind of getting everything up and running. But since then, looks like a lot of those issues have been resolved and things are moving smoothly now. That's basically it. Oh, actually, I have a couple more. There are 5 instances of noncompliance within the quarter. Most of those instances of noncompliance were minor violations for things like not being available for quarterly interviews with their probation monitor. And most of those are from out-of-state folks who have no interest in retaining their license here. So they're kind of ghosting me at this moment. And I would like to remind those people that if they continue to do that, they will face revocation eventually. So now, any questions?
Thank you. Any questions from the board? I did have, go ahead. Mhm. Oh, okay. Yeah, I was aware that Maximus is what we lost. Is that correct?
Yes, that was the vendor previous.
And who are the other, is it a DCA-wide contract change?
Yeah, so 7 boards are a part of that contract, basically the health-related boards. And so, yes, all of the boards are now with Premier on that contract.
And so the transition was a little rocky. How did it impact you?
We had some licensees that were obviously very concerned. It's a big part of their probation if they're required to be in that program. There's a lot of stress involved with it because there are a lot of deadlines and things that you have to do daily, checking in for testing, going to test, checking in with the clinical case manager, things like that. So while their staffing was kind of getting settled, licensees were having some trouble reaching people at Premier. The clinical case manager who was assigned to our licensees changed like 5 times within like 3 weeks. So they were trying to get the staffing, under control, but that was obviously causing a lot of stress for our people not being able to reach their clinical case manager. And then those calls were coming to me because they were starting to stress out about being compliant with their probation.
That makes sense.
So I was able to calm all of them, tell them, hey, I understand this is stressful, but it's not going to be held against you as long as you're trying to do what you are supposed to do. I understand, it may be out of your control. So, but like I said, those issues have resolved themselves and everything's working smoothly now.
Was it part of the DCA's process to transition all of the applicants or the probationers' information, like as part of the transition to the new company?
Yeah, so Maximus, the old vendor, gave Premier access to all of that information that they
Okay,
had.
it wasn't on the probationer, it wasn't on us.
It was on Maximus to do that.
Okay.
They agreed as part of the transition phase to help us out with that. They didn't have to do that, but they were very gracious in doing that.
Last question. Have you noticed any benefit in this system that Premier has that maybe
seems to be
is going to be
working
helpful?
well? I've gotten some comments about how they're more responsive and answer phones more readily than our other contractor, but other than that, I haven't noticed too many changes, so that's a good thing.
Okay, good. Thank you.
I think one of the things that I noticed in the transition is department-wide. The other 7 boards that were involved in that contract were all kind of taken aback that this was even going to be a contract change, right? So Maximus had been a contractor for that program since the early 2000s. But they did give us plenty of notice, to be fair. And that, I'm sure, for probationers, as part of their participation in that program, could be unsettling in and of itself, right? This is part of their recovery. They're used to certain health support group meetings or dealing with a specific case manager. Now they're being told that that's all ending on January 1st, and there'll be some new information coming forth. So to Monty's credit, we did relay the information to them that there was a period of time where we didn't have the answers to their questions, but we did assure them that those things would not be considered violations against their disciplinary order. It would be kind of an impossibility of law for them to fulfill those things. So there was a bit of an outreach campaign that needed to be done. The transition over, the data transition, the Department of Consumer Affairs OIS team was very instrumental in taking the data from one system and plugging it into the correct place, into the new system. And so there was some art, if you will, involved in that process. So we appreciate them making it as smooth as they did. One of the other things that I think is kind of a benefit is the contract, because it was newly negotiated, was at a lower rate than previously with Maximus. Now, like most contracts, it will have cost increases built in yearly, but the probationers themselves got to realize a little bit of cost savings as a result of that. So,
Any other questions or comments from the board?
Thank you, Monty. The 12 who are tolling in state,
Yes.
I'm trying to find out if it is a real struggle for these probationers to find work.
Yes, some of them are. How do I put it? Certain techniques that they've done in the past have made it more difficult, I would guess, for them to be hired. It really just depends on your terms. So most of the people that aren't working can't find jobs, and most of the ones that can't find jobs say they can't find them because they can't find a supervisor who's willing to supervise them for their probation. A lot of people, when they're looking, a lot of PTs, when they're looking to hire people, are looking to hire a PT that can do evals and kind of work on their own. And if you're on probation and require supervision at least once per shift, it's not really worth it for that company to hire you and have two PTs there when one could be doing the job. So in cases like that, it can be difficult. It's just finding the right placement for the right licensee at the right time.
Yeah.
A lot of times it comes down to luck.
I'm thinking, obviously, we're not trying to be punitive. We want these people to find work. We want them to complete their probation successfully. And I can think of different settings that would love to have an extra PT. So I was just trying to wrap my head around people not being able to find work, and it's not our job to help them, right? But
I do get that question a lot. Can you help me?
yeah,
I have people in remote places that have a hard time if they're on probation. I know of one owner of a company who recently had a probation or complete probation asked me, if you know of any other people on probation, this was a good experience for me. Here's my contact info. Let them know that I'm here, which is helpful.
yeah.
But if you're like in Bakersfield or something like that, it can be difficult to find jobs.
Yeah, I don't doubt it. And especially if there are specific terms that, certain places can't meet, accommodate. But when you say Bakersfield, I'm thinking they need PTs. PTs are needed everywhere. And so, yeah. And so I'm not in any way insinuating that they're not trying to find work. I think their struggle is probably very real, but I do think that there are opportunities out there. But maybe there's just some assistance that's needed. I don't know.
We've looked at this in magnification a couple of times throughout the years. I think if you remember, public member Carol Wallish had us kind of do a deep dive into this topic. And one of the things that, just to keep in mind is of those 12, the employment difficulties might be rooted in a number of different things, right? It might be they can't be employed in the settings that they particularly would like to be employed in. The employer's insurance or third-party payer agreement won't allow for their credentialing of their practice if they have somebody on probation in that practice. So that limits their ability. And really, even sometimes the detail in the disciplinary order, in the accusation, because of maybe the egregious nature of what got them in trouble in the first place, can be kind of the tiebreaker or the disqualifier for employment. When they have a choice between someone with discipline or without discipline, they're going to choose the person without discipline. So the numbers of 12, it's fluctuated over the years. But when you put it in the context of the 66 that were successful in finding employment and working, it gives you kind of an idea of just like the severity of the variance between the two.
Yeah.
I don't know if I should mention this, but one question I've been getting recently is about telehealth and people on probation doing telehealth. And so we're just trying to figure out how that might work with their terms as well. And that may be able to help some people that are in kind of those areas where it's kind of harder to find a physical place to go work.
Yeah, interesting. My last question is, when you meet with probationers, do you find that you are still making calls, doing virtual visits? Are you doing in-person visits?
At this point, it's mostly virtual unless we need to go out and see them personally. With just me being the probation monitor, I feel like that's the most efficient way I can at least talk and see everybody every quarter that way. If I'm traveling and, driving in the LA area, I might see 3-4 people a day. And half of my caseload is in Southern California. So I would have to be down there 2 weeks, to see all those people. So it makes it nice that I can cut that time in half basically and physically see everybody and talk to everybody.
Thank you. Any other questions or comments? Jason, how and when can we find out about the possibility or how it's written into our probation regarding telehealth? Is that considered part of the independent practicing that oftentimes is restricted?
So without any kind of language prohibiting the use of telehealth in the disciplinary order, the licensee would be able to exercise telehealth the same way any other licensee would be, right? So as a tool not meant to replace normal standards in practice. So currently, there's really nothing prohibiting them from utilizing that tool. There may be instances in the future based on, say, the behaviors that led to the discipline where we might want to restrict something like that, but we haven't thus far.
I think where it happens is it working with the other terms and conditions of probation.
Supervisory.
Yeah,
Yeah.
you're required to be physically observed at least once per shift. How is that done if you're doing telehealth? Things like that. So it still has to be compliable with the rest of the terms. So.
Makes sense. All right, thank you. Thank you so much. All right. Any public comment on probation monitoring services report? No? All right. All right, I'd like to go to 23 agenda items for future meetings. And then I'll go to that one.
I have ideas. I might not be sitting here, I might be sitting out there, but anyway. I am wondering if sometime in the future, President Brandon, you might consider a discussion on ENMG and KEMG and the board's role with that and the board's future role with that. I also, a second item would be just to follow up with the FSBPT liaison, Michelle's report, and consider maybe a agenda item for anything that our board might want to bring forward to life for consideration.
All right, thank you. Anybody else, any items that want to bring forward for next meeting in June? I would like to consider putting on the agenda the conversation about exempt position placement for our EO in terms of next steps and what the requirement is from the Office of Human Resources and the process with which we would put forward a request for that. Is everyone comfortable? Okay. I don't know if I need a motion, but I think we're definitely going to keep it in consideration.
I have one more.
Yeah, go ahead.
Okay, I have one more. Thank you, President Brandon and Mr. Kaiser, for allowing these presentations this morning regarding dry needling. And I'm just throwing it out there to possibly have a follow-up agenda item for the board moving forward on any action, possible action regarding dry needling.
All right, thank you. Anybody else, any more ideas for next future meetings? Okay, I'm going to open to public comment on this item.
Dr. Michelle Lau, and I just mentioned that I would like to request a presentation next meeting or in the future, if that you allow, to talking how we can work together with as a profession acupuncture. I representing the Council of Acupuncture and Oriental Medicine, also the Acupuncture American Alliance Acupuncture of Acupuncture. So we like to have a short presentation and talking how does acupuncture work and how dry needle work also in our point of the view, and then to try with the education everybody.
All right, thank you very much.
Thank you. I will send a request to the EO.
Thank you. Any more public comment on this item? All right, I'm going to go back to item number 7, because I think we have a special presentation for one of our outgoing board members, a person that we usually talk about shoes to fill, but in this capacity, I think that it's really significant in terms of like hands, because when I think about servant leadership, I think about you. I think about how you're completely humbly willing to serve in any capacity that you can be useful and able to speak to anybody on behalf of the things that you believe in and that you're passionate about. And your integrity is remarkable. And we are so going to be missing you on this side of the dais. I can't even tell you. So come on up. We're gonna.
If I could have the president. Sorry. Front with us.
Trigger.
So.
Oh, okay.
Sure. This resolution. So.
That is something the president Thank you. Beautiful. Now you gotta think that. Last you'll see. I'll be coming up to here for public comment. Yeah, thank you. Passing the baton. Yes.
Okay, so at this time, we are going to go into closed session, which is our final one, item number 24. And can I actually say, is there anything more? Well, we'll be adjourning from closed session at that time. I don't have to say the time. Okay. Ah, thank you so much.